Bwrdd da pawb a croeso I cyfarfod bwrdd Cyhoeddus. Good morning everybody and welcome to public board meeting of Hywel Dda University Health Board. Can I begin first and foremost by a number of welcomes and then looking at some apologies. Before we do that, can I just confirm that people received the papers in good time? And that they were clear and comprehensive. And is there anything that you felt were omitted from the papers that we may need to discuss during the course of the meeting? No? Okay, thank you. And as usual, I kind of like to remind people of some of the decision-making principles that underpin the way we make our decisions and ensure that we're consistent in what we do. Our decisions are fair, they're affordable and sustainable, they're consistent with our strategies, so they align with what we are trying to achieve in the mid and long term. They're not creating unhelpful precedents, so they allow us to ensure that there is a consistency in what we're doing, and at all levels they are safe. So the decisions are fundamentally leading to safe outcomes. In terms of apologies, then we've received apologies from Sharon Daniels, who's away, and I think Mandy, you've joined us. Great for you to join us today. And also apologies from Mardiana, and I think Bethan, you joined us in Ardiana's place. And we've had apologies from Michael Gray. We have some other additional people around the table. I'd like to extend a very warm welcome to Moape Burke, who's joined us today. We would have met with Moape online in the past. Moape joins us as part of the Shadow Board non-executive scheme. We're delighted she's joined us. She's already added some real interest and value to the conversations we've had. You're very welcome, Moape, and feel free to contribute to our conversations and our discussions around the board today. We will also, I think, Dr. John Arthur has also joined us today. Good to see you, John. And I think we have Audit Wales observing online, and Donna Coleman will be attending online as well. We have a number of people joining us for particular items. So Dr. Karen Brown and Peter Skitt will be joining us for the integrated urgent and emergency care model discussion. And Sam Hussle, Head of Health Emergency Planning, will be joining us for that item when we discuss it later in the agenda. Great, okay. Can I begin by asking if there are any declarations of interest? No? Thank you. Can I then move us to minutes of the public board meeting held on the 29th of May? Are there any issues that people would like to raise regarding the minutes? No? Great, okay, let's accept the minutes. Can we turn to matters arising and table of actions? I think you can note that all actions have been completed or will be completed after today's meeting. A number arise for us to discuss during the context of this meeting. Great, okay. Can I then turn to item 5, which is report of the chair? I'm not going to run through this in detail. I'm presuming you've read it and are cognizant of some of the things I've got up to over the last 2 months. The point I'd like to draw your attention to, which I think it's worth us briefly capturing, is you will all know that we are deeply immersed in the clinical service plan consultation, an extensive programme of engagement with communities, with clinicians, with all stakeholders involved in that process. I've had the challenge and the honour of being able to attend some of those events across West Wales, which has been deeply insightful and and immensely valuable, largely because it's an enormously, it's a humbling experience, frankly, to listen to people's stories of the services we provide. Some of those stories have been difficult to hear, and some have been delightful and joyful. It's a combination of the two. And but inevitably, what it kind of said to me is what we deliver impacts significantly upon the well-being, the health and happiness of people within our communities. And that when we think about making decisions related to the clinical services plan, those are paramount in the way in which we make our decisions. That the reflection we all may have had during the course of our consultations should be part of that decision-making process when we come to November, or if it's later than November, when we come to the point where we need to make some critical decisions regarding the clinical service plan. I'm really pleased to have been part of the process. I'm sure you are too, and you may want to comment on it. And I'm grateful to the people who've attended those sessions and with passion and with commitment have shared their views and their thoughts and taken time to tell us what they think. We have learned enormous amounts about the way in which we deliver services, not just about the clinical service plan, but about all kinds of things, which I think is invaluable for us as a health board. Any comments? Jill.
Chair, thank you. One of the key meetings that you attended was the Pembrokeshire Peninsula Stakeholder Group, and just related to that, Chair, it was a year ago that the board made a decision to manage the dispersal of the St David's practice patients and to set up Meddygfa Penrhyn. And board members will recall that we were asked to go back out to engage with the public 6 months after the opening of Meddygfa Penrhyn, which was on the 1st of November. So we completed that in June with 2 stakeholder engagement events on the 24th and 26th of June and an online questionnaire as well. And I was wondering, as it was the board who had commissioned this, whether it would be appropriate to bring this back to a subcommittee of the board or to the board itself for understanding really of the experiences of our patients following that, that establishment of Meddygfa Penrhyn.
Thank you. To my recollection, the Chief Executive and I attended a really helpful meeting in St David's, I would add. I thought it was quite a rich conversation. As you would expect, there were a lot of very informed and experienced people around the table. My recollection was that we invited the Peninsula Group to the board to share with us their thoughts and views in January of next year.
Yes, that's a slightly separate issue. So we've got the ongoing community engagement with the Peninsula Group, and you're absolutely right. They're looking forward to that opportunity. This was going out to the wider community on the 24th and the 26th of June to hear general views from members of the public who may not necessarily be part of that meeting.
I wonder.
Apologies for any confusion.
No, it wasn't confused. Naively, I was wondering whether we could combine the two in January. Unless, of course, it's more fruitful for us to hear those views at an earlier time, Joe.
That might be a good idea. We had a follow-on meeting from the Peninsula Group, and I formally took the record of those events to that meeting so that they were covered off there, and there is some learning from that. But hopefully that learning, as you say, will enrich the process that the community wants to take forward. So I'm happy that we use that as the opportunity if that's what would be helpful.
Great. I mean, I'm very excited that they come back in January. I think it's great to see a community come together. I don't think by any stretch of the imagination it's an easy task. I think it's complex and difficult working with different interests, different aspirations, different understandings of what we're trying to deliver. But I think that's the journey we need to take when we think about how we work with our communities to help deliver local health. So it'll be really great to hear them come back in January. Thank you. Eleanor.
Just a minor point for correction. I attended the All Wales planning event here in Carmarthen, not in Lampeter.
Great. Okay. Thank you. Great. Okay. If we are happy with my report, let's move to item 6 and the report of the Chief Executive.
Diolch Cadeirydd, bore da pawb. Good morning, everyone. So a couple of things I did want to highlight in the report. mean, first of all, like the rest of the board, I was really pleased with the announcement that we were going to be further de-escalated in a few areas. So whilst that's small progress, it's significant progress, I would say, and it also builds on our de-escalations that we had in March. So it does feel like we're making progress in that regard, and you'll see the letter from the Director General in the attachments. So we've been de-escalated to level 3 for cancer services and to level 1 for child and adolescent mental health services. So really delighted and proud of the staff who've worked so hard to make this happen. On the emergency medical retrieval service, you'll see there's a brief update there in my report, but there's a further update that I'd like to give you because it's very recent, and that is that the permission to appeal has been refused on all grounds. The order was sealed on the 1st of July, but it was only served by the court on Tuesday, which is 2 days ago. This means that the time period for the application to the Court of Appeal has now passed. So in essence, permission of judicial review on ground 4 is refused and claim dismissed. So it's just so we have the latest information as a board. The other area I wanted just to highlight was before we move to the recommendations, because there are a number of items for approval and endorsement. I did want to congratulate Mark Henwood publicly on being appointed as the substantive Executive Medical Director. So many congratulations. It's a role I know quite well. So yeah, no, well done, Mark. It's great to have you as my successor in that role, and many congratulations. And Mark, actually, I was going to come to you because we did have an inspection of our A&E services in Bronglais General Hospital in the last few days, and we have had our initial feedback whilst we wait for the full report. So I thought it was helpful for the board to hear the initial feedback.
Yeah, thanks very much, Phil. So yeah, Health Inspectorate Wales have been carrying out an unannounced visit at Bronglais General Hospital ED. They came on Tuesday evening. Myself and James Severs, our Director of Allied Health Professionals and Health Science, attended the feedback session yesterday afternoon. That's an initial feedback session where we just get initial feedback, but we'll get a full report subsequently. I think what I'd like to do is just mention that there are issues that they very much recognise that we are aware of, issues with flow, issues with staffing that we are currently working on. There are some immediate actions that we are required to take. I think most of those we can cover off very quickly, and I don't think would be particularly an issue that I would need to report to the board. What I would like to do is particularly mention the positive feedback that they've given about our staff. And I'm sure we all as a board want to really congratulate and thank our staff in Bronglais ED. I could give you some quotes from the team, the Health Inspectorate Wales team. They said it was an unusual experience attending Bronglais ED because of the positive culture and the attitude of the staff. And the quote was, obviously they're doing a lot right. And I personally, I'm sure we all are very proud of the staff who engaged with Health Inspectorate Wales and showed a very positive attitude to that. Health Inspectorate Wales do get some immediate patient experience feedback, and they said quite unusually also that was overwhelmingly positive. So I think it shows all the excellent work that is going on. Also, there are some improvements, but I think what's good to know is those staff are very committed to those improvements. So I think, yeah, as a board, we can be very proud of the staff in ED in Bronglais General Hospital.
Well, let's register our thanks, part of the minutes, to the staff of Bronglice Hospital, because it's an enormously pressurised service, and that's enormously reassuring to hear. Great.
So other than that, Chair, I'm happy to take, I realise there are a few other items, but I'm happy to take any questions and also then move to recommendations.
Great. Colleagues, questions? Ewan?
Diolch, Cadeirydd. Thank you, Phil, for the report. More a bit of an observation than a question, if okay, regarding the Regional Integration Fund. Great to see in terms of the agreement in place between the local authorities and ourselves as a health board. One of the questions which certainly comes up a lot across the third sector on the regional patch, as it were, is around RIF and in relation to match funding. Now, as we know with RIF, it is a decreasing kind of fund in terms of whilst you get 100% in the first year, it decreases then. There's an expectation on the third sector to then contribute cash during years 3, 4 and 5, for example, particularly. With the increases to NI and the challenges around the third sector across the 3 counties, a lot of third sector projects, charities and organisations are struggling now to actually fulfil the match in terms of a cash contribution. So a lot of the projects now across the 3 counties are at risk in terms of their continuation, and some of the CVCs are already looking at a potential either mothballing or stopping projects altogether because of the RIF expectation on cash match funding. However, within the document it does state that there will be an ability to look at match funding in terms of staff time and volunteer time from statutory partners to then compensate in terms of looking at the additionality which these projects bring to our statutory services across both health and local authorities. So it's just really for noting, I suppose, in terms of whether we as a health board can support in terms of looking at the encouragement of using match in terms of time from our statutory partners, as opposed to putting the kind of unnecessary demands upon the third sector and charities in terms of a cash match, because the guidance clearly states it, but there is still an expectation that the third sector has to stump up cash on an increasing basis, and if they can't, there are hundreds of people, if not thousands, across the region who will not benefit from the services they're actually getting at the moment.
Hugh, did you want to come back on this point or something separate?
Jill's got her hands up, but I'm happy to come in as well, yes.
Jill?
Thank you, Chair. And first of all, I think we want to recognise the really important role that our third sector play in terms of supporting our services, but also the benefit of funding opportunities such as RIF, which we know has been in place for a few years. And what Welsh Government did was actually slow down that tapering process, which was meant to have happened in earlier years. So we recognise the benefit from that perspective. The funding, as my colleague has said, does go up until 2027. And what the Regional Partnership Board is being asked to do now is to look at those projects that are currently being funded and to review those against what are revised criteria that Welsh Government have produced. So at the next Integrated Executive Group, which is part of the Regional Partnership Board, we're looking to sign off the process that will be undertaken to review each of those projects against the criteria and then to be able to consider which of those can be supported in the way that Ewan has suggested. Now, there's no guarantees at this stage, but the expectation from the funding is that statutory partners do look at scaling up some of these projects, but that has to be considered in the round, along with other things that partner organisations have to support. But we know that the strategic direction of our health board and local authorities is to empower individuals to maintain that independence and to work within our communities. So I'd like to assure Ewan that there is a process that is being reviewed that will be very transparent and will engage our partner organisations in terms of that, but not ready to bring back anything formal at this stage.
Okay, thank you. Well, let's not script this. It's important. I think you make a compelling argument, Ewan, for why we need to find a way that we can support our partners in this process and in very difficult circumstances. So let's grip this and have a long-term view on the value that these organisations are bringing to the delivery of health services. So well made. I'll come to Hugh and then I'll come to Anna.
Yeah, Chair, just echoing what Jill said, but just to add to it, I think there is a challenge for us as an organisation in terms of the nature of funding streams like RIF, like cluster funding, like degrees of funding that we're getting in mental health services as well, where they are non-recurrent by their nature, and we have people who have been employed into fixed-term posts. That does give us a workforce challenge and a financial risk that we need to recognise. I think that's as part of our planning for next year. We need to be really explicit about the level of risk that we are carrying as an organisation, but it has been an enabler for shifting resources into our community, which we know is the long-term direction of travel we need to follow anyway.
Great, thank you very much. I'm going to come to Anna and then I'll come to Chantal.
Thank you, Chair. Bwrdd Pab. I wonder if I could take the Chief Exec back to the news that our child and adolescent mental health services have been de-escalated from level 3 to level 1, which is a fantastic result. But I wonder if you could just elaborate, Phil, on the rationale for that de-escalation and what that means for local families and the expectations they can now have in terms of improvements in quality, safety and experience for children and young people in West Wales.
Yeah, and I might bring the Chief Ops Officer in a sec just to give him a little bit of time to think. I mean, I'm delighted that we've been de-escalated to level 1 because it's and we've been de-escalated because of some of the measures, the way we are measured on child and adolescent mental health services. Having said that, and I'm sure this is what could be behind your question, there are all sorts of aspects of our child and adolescent mental health services which we know the access for people is not as we would want it, and we've discussed this many times around this board table. So particularly neurodevelopmental services, we have to recognise that the waiting times for people for those services in this area, and indeed widely, but particularly this area, are nowhere near we'd like them to be. And we, in fact, our plans to improve them, whilst they've given some small improvement, are still nowhere near where we would need them. So I do think it's right that and proper that we make that point here. Don't know whether Andrew may have something to add to that, though.
Cadeirydd, if you don't mind, I have a very similar point that I was going to bring up in a later report, which Andrew might want to pick up at the same time.
Okay, if you want to share that, and then we'll come to Andrew.
It was about the de-escalation, and I remain concerned about this area because demand is outstripping capacity. And I am concerned not only about the expectations of people needing to access the service and their families, but also the staff working in these services who are overwhelmed by the demand that is on them. And I was again going to ask about what plans are in place to improve the service. Delighted it's de-escalated, but it doesn't take away those primary concerns.
Of course, and it doesn't mean we should take our foot off the pedal. Andrew.
Yeah, thank you, Chair, and thank you for the questions. I think I think it's an important conversation because I think what we need to be really clear on is the de-escalation is around some specific performance targets that we've managed to make significant progress in terms of our delivery and performance improvement on since the time at which we were escalated 18 months, 2 years ago, and there had been a challenge on and off since before. Oh, well, sorry, since COVID, not before COVID. We were right before COVID. So against those specific measures, we have it is what the de-escalation recognises and the progress against those two specific targets. The wider questions around neurodevelopmental services and some of the other aspects of our service provision for children that have mental illness of some kind is still a significant challenge for us, as we've recognised and discussed at the board previously. And I know that there's that's still very much the focus for us operationally in terms of how we provide a more robust service on a broader basis, not just against the couple of measures that we were being specifically scrutinised on as part of the escalation. Neurodevelopmental services was originally, from a Welsh Government perspective, one of the things they had included in that in their escalation framework, but due to a recognition nationally that the targets they were measuring us against were probably unachievable for anybody, they removed it. So whilst it's not part of the escalation framework, it does still form part of our local performance reporting and our local position. We have agreed, we received our integrated quality performance and finance delivery group a couple of weeks ago in a revised terms of reference for a specific project that's going to look at, which James, Director of Allied Health and Health Sciences, has been leading with the team around how we properly redesign the service to meet the demand that's being placed in it, because as the Vice Chair's rightly pointed out, demand is outstripping capacity at the moment. So that is an important piece of work that we haven't lost sight of, and I wouldn't want to give the impression that I'm obviously really grateful to the team and the hard work they've done on the measures that have been de-escalated, but we all recognise there's a lot more for us to do in this space, and whilst in a couple of areas we've improved and will have mitigated some risk and improved some experience, we know there's much more for us to do, particularly in the neurodevelopmental service domain, and that's a real focus for us over the next few months.
Thank you, Andrew. I mean, speaking on behalf of the Vice Chair, I suspect we are reassured there is work underway to develop a sustainable solution to the demand that we're experiencing in this area. So I think that is really important for us to be able to recognise that there is ongoing improvement, and it isn't just trying to mobilise more quickly. It's about looking at the service model that we're using to be able to better meet the demand of the population. Perhaps we could be further informed of that as we move forward into the future to receive the assurance that we need. Great, okay. Thank you. Sorry, Chantal. Yes, of course, you wanted to
That's
come
all
back
right.
in.
Thank you, Chair. There are just 2 points I wanted to raise. One is in relation to the RIF, and I heard that Jill made the comment about the fact that the current projects are going to be under review. Presumably, when we're looking at the review of those projects, that we'll be looking at the evaluation and the impact, in particular in terms of the groups that are benefiting from the funding currently. So, I would hope that would be part and parcel of almost like an independent assessment of how well those projects have been delivered and the impact that it has had.
Yes, Chair, thank you. A very helpful question. And just to reassure you that throughout the duration of the RIF funding, regular reports are provided both to the Regional Partnership Board and to Welsh Government to satisfy and demonstrate that those outcomes are being achieved. And obviously there are some projects where perhaps less progress has been made, and that will all inform the evaluation process. And I'm happy to take the RIF process that we'll be using probably through the Strategy and Planning Committee, where we usually do our RIF update reports, so that board members can see the process that will be used. But it will absolutely look at that evaluation and also have the forward look as well in terms of the issues that we need to address going forward as well.
Thank you very much for that. The second question was in relation to the demand outstripping capacity, in particular in terms of mental health services. Have we looked at why suddenly the demands has increased? Is that because there are gaps in the services that's not supporting individuals before they get to the point where we are having to deal with as far as Hywel Dda is concerned?
Very good question. It's where is this originating? Well, Andrew, can you, it might be speculative, but you're very happy to respond to that.
Yeah, very well. I'll try to respond to it because I think it's a really good question. I think why is demand outstripping demand? I think there has been, since certainly over recent years, and I think the pandemic provided a catalyst for this. There's certainly more awareness of mental illness and mental health impact, and particularly mental health impact on, and the impact that can have on children, not just adults. I think that's become very clear and much more in everyone's conscience. I think the impact of the pandemic and the experience that a number of our young population had, where they weren't able to have their normal education and schooling as all had, and the kind of there's a lot of research and evidence out there around the impact of the can't think of the word now. I was going to say isolation, but it's not isolation. Lockdown. That was the word I was looking for. Sorry. The impact that lockdown has had, particularly on our younger generations and their development and their growth. So I think that's very much more very much something that everyone's aware of, and so more people are coming forward, I think, with concerns to that effect. I think the interesting thing and the challenge we've got with the service, and this is partly why Welsh Government, I believe, felt the current model wasn't really going to ever be achieved. But what we do know from our local assessment is the target at the moment that we're measured against is the time to assessment. But we know that based on the referrals we get, 90% of the referrals, roughly, or just about 90%, certainly more than 85%, our assessment just confirms the diagnosis that the referral has already made. And the actual challenge we've really got is the capacity we've got to provide the treatment and the intervention that follows the diagnosis. So at the moment, there's sort of two bottlenecks. We're measured on a time to assessment when actually we know with the referral we receive, most children have probably, or if it says they think they've got a neurodevelopmental diagnosis, then in 85 to 90% of cases they have. But then it's around how you provide the intervention, and the complexity with the intervention is it's not just a one-off service provision or session, it's a series of sessions over a period of time. So the level of capacity you then need to be able to put in place as you're doing those assessments is the real challenge. What we're trying to work through and what the scope in the terms of reference is around is how do we change that process a bit more. You remember we did try a pilot where we redirected some of our resource into that, into more of an MDT approach. That probably didn't give us the benefit in terms of access that we were looking for, hence the revised terms of reference that we've come up with for a new scope. But I think it's very much around what we're really wanting to focus on is how do we actually address the issue, which is more about how do we provide the intervention, the treatment and care, which there'll be a variable scale of that depending on the severity of the diagnosis. In some cases, that will just be the requirement for support for the family and the individual at home. Other things, it will be more of a specialist intervention. But it's how do we right size our and frame our, reprioritise our resource, which is limited, to target those issues rather than the front end assessment so much, because the assessment, and with AI and various tools that we're looking at, there are ways that we can really speed up that front end to get them into the treatment pathway much quicker and put them into the right treatment pathway. Because as I say, some of those could be quite quick to access because it might be about counselling online and other tools and educational programmes. Okay. Sorry, that was a long answer, Chair.
It was a long answer. Fruitful, though. Lots of interesting things in your response. And I suspect part of the rationale behind your question was, is there anything we can do further upstream to influence the mental health of young people, positively, so that actually the demand on the service is less volatile or voluminous? And I think that's a question we need to ask ourselves. Bethany, maybe something to think about.
Yes, certainly, Chair. And I know it's part of the 7 of the pathways of the 24/7 framework. Mental health and well-being is one of the key pathways that we'd explore in there, and how we can feed prevention into that work stream.
Diolch. Okay, in the interest of time, I'm conscious we're slightly running over. I'm going to move us forward. Did you want to say anything before we agree the outcomes of your report?
Well, only just on Joanne's point about our public sector staff volunteering to cover a gap. I suppose maybe I think that's something we'd want to explore. But I think maybe the assessment that Jill was suggesting doing first, and then we can work out what the gap might be. But be open to explore it.
Great. Okay. And then, so just to close this item, can I ask that we note the escalation status update and letter, which is attached as Appendix 1, which I think we'll come back to in our financial reporting in a minute. Note the corporate risk register report and summary, which is Appendix 2. Approve the deed of variation, 25th of 35. APB and Bwrdd Project Limited, Appendix 3. Approve the signing of the Regional Integration Fund Memorandum of Understanding, Appendix 4. Approve the resigning of the application of the Health Board seal to the lease agreements linked to the continued delivery of renal services at Glangwili and Withybush hospitals. Endorse the register of ceilings since the previous report on the 29th of May 2025. Note the status report for consultation documents received and responded to in Appendix 6. And note executive team discussions, Appendix 7. I'm not seeing any disagreement or any... Great, okay, thank you very much. Let us move to item 7, which we're moving into delivering our purpose part of the session, and we're going to go to the annual report.
Diolch, Cadeirydd. Thank you, Chair. Good morning, everybody. So the first item that we're considering here now this morning is in relation to the annual plan. So we have provided... Sorry, the microphone. Okay, apologies. So the paper provides an overview of the key delivery expectations within our agreed annual plan, with particular reference to the target intervention requirements which the plan was originally built around. Naturally, there are a number of components within the annual plan that are also covered by other items on the agenda, so I think it's quite beneficial that this item comes early up the agenda, and my suggestion, Chair, would be that we then take the relevant aspects in the subsequent items where it's most appropriate, if that's helpful for the conversation. The key points I will highlight for board, though, just at this stage, is that following submission of the Health Board's annual plan, there have, as you'll see, been a series of letters exchanged between ourselves and Welsh Government. The further letters are included within the pack for board consideration. The letters indicate quite clearly that Welsh Government deem the Health Board's plan unsupportable, and primarily that is, as we understand it, due to the financial forecast of the Health Board. It should be noted that at the time the plan was developed, it was designed to respond to the Health Board TI requirements. That was how we constructed the plan. And of course, in the finance domain, the key TI de-escalation criteria is delivery of the target control total, which of course the plan does aim to deliver. Nonetheless, because last year's position finished somewhat better than the target control total, Welsh Government are now deeming this a deterioration in our financial position, and the finance paper picks up the latest position in this regard. So I think we'll return to that conversation under that item. As a further update, yesterday we received our accountability conditions, which are also now provided within the papers, and we had our quarterly TI meeting with Welsh Government. The second point I highlight is that from a performance perspective, naturally we'll come on to these points within the IPAR conversation, but the paper highlights where we are in relation to meeting the TI criteria. Most notably, in a positive sense, cancer performance has improved, as Phil identified, and that has resulted in that being de-escalated. There are areas identified which are improving, but are not yet at the level of the TI criteria that we've been set. And then there are some areas identified as cause for concern, which obviously we'll return to within the IPAR. I think the more significant of that being urgent emergency care, which of course we've got an item on later as well. That is now the only performance area, strictly performance area, that is at level 4. But we also flag follow-ups, ophthalmology, and then IP and C as a concern which was improving but has been challenged in recent months. The final point, just to highlight to board, is that we have some challenges from a workforce perspective within theatres, which is referenced within the paper, and that is in Glangwili in particular. The clinical care group are working on a plan to respond to that, and we've had some discussions with the clinical care group in relation to that, but we'll obviously be keeping a close eye on that, as that will be a key component of delivering the rest of our plan for the remainder of the year. So I'll stop there, Chair. Thank you.
Great. Okay. You make a very important point at the start of that, which is we're obviously, in a number of these papers, the finance update and the IPAR, we are repeating our discussion of several items. So let's try and I would quite like us to shift the issue of finance from this paper into into the finance paper, so we discuss it once as opposed to several times. So if you do have a question relating to that, let's leave it till Hugh's presentation and discussion and have the conversation there, rather than repeat it. But broadly, colleagues, thoughts or questions in relation to Lee's item and the annual plan? Rodri.
Yeah, just one question regarding the ophthalmology in our one performance. If we look back to the Chief Executive's report, we've reduced the risk from 20 to 16 on ophthalmology, but then reading this report, it doesn't sound as if it should be perhaps reduced. And I'm just wondering, because we're only 35% here, so it's a minimal improvement. I just wanted that justification that the risk has been reduced by 4 points.
I'll let Andrew.
Andrew.
Yeah, so just on the risk, the issue with the risk related to medical rotas and medical cover and on-call arrangements and such like, not specifically some of the service access or waiting times issues. So we've seen an improvement in our medical recruitment position within ophthalmology, hence the reduction in the risk. So not directly related to the same issue that's called out in the paper, which I believe is a separate risk on the Director Risk Register.
Great, thank you, Andrew. Eleanor and then Anna.
Diolch, Cadeirydd. I have many questions which will come up in the finance paper. The one relating to this, and thank you, Lee, I thought it was a really good and helpful paper taking us through it. It's about the do not attend. The question for me is, does each individual department do its own appointments? Can people book online? When I'm out and about, hear many instances of letters arriving after the date of the appointment. I think we are slightly nervous around text ones when actually most people have mobile phones. Is there a better way to be doing this, and what work is going on to make sure that we maximise the number of people attending appointments? It may not be a Lee, it could be a Lee, Andrew, Hugh.
Yes, let's take a couple of questions, and then, because I think that's a very pertinent question, because that came up in my reading of the paper as well. Let's take a couple of other responses and then come back. Anna.
Thanks, Joe. I wanted to ask a question around theatres capacity. So if my reading of that paragraph is correct, we're losing around 20% of our theatres capacity as a result mainly of shortfall in our substantive workforce, and there are various explanations or a bit of detail around that. But then that last sentence refers to policy limitations on additional hours or agency support. I would just like a bit of elaboration on those policy limitations, please.
Great. Okay, should we take those two questions first? So, Lee or Andrew?
Probably Andrew, I think. Is that okay?
Andrew.
I thought you might say that. So just coming to the Vice Chair's question around do not attend or did not attend, and some of the postal issue. So I think there's a lot of factors wrapped up in that. What seems like quite a small question, but there's a lot in there, and I think you make some important points around how are we currently communicating appointments, and certainly one of the things I've picked up from some of the CSP engagement and some of the wider conversation is a desire for more text message appointments rather than letters all the time, which has been interesting. So I think there's a couple of things. I think we're still trying to understand what the issue with the late appointment letters is. So that's come up as a theme, we know, through some local media reporting over the last month, and also it's something we hear raised through the staff partnership forum as well from worried members of our organisation. But it's not something we ever get complaints about formally into the organisation. So trying to understand, without having the detailed individual experiences or circumstances, it's hard for us to really understand what's going on there. We think there might be some link to, we don't think it's to do with process. We think there might have been some impact at a point in time around moving from first class to second class postage, but beyond that at the moment, we're still trying to understand exactly what that is. And what I would say is, if anybody, and I know we have responded in this way, but if there is anybody watching or listening or looking back at this that has experienced that issue, please do get in touch with us and talk to us about it, because I would really like to understand some of the detail of that a bit more, because if we have some individual specific cases, I can look into those into real detail and get a much more granular understanding of what that is causing that specific issue. What I'd also say is whilst our outpatient appointments are generally centralised through our booking centre, which is housed in medical records, there are a number of other departments that book their own appointments. So our overall booking and appointment process isn't necessarily consolidated into one place. So therapies will book their own clinics, radiology will book their own clinics. There are various different services that will do that independently of that main booking centre. And that's also why this becomes quite a complicated topic, because actually there are numerous different parts of the organisation that this could apply to, and some of the feedback again isn't specific in terms of which specialties or which services people are experiencing that challenge with. So as I say, the more information in a more granular form I can get, or my teams can receive, the more we can properly get underneath some of that issue and challenge. So I would welcome that kind of more direct feedback or specific feedback from any members of the public or staff even, because there are patients as well that are experiencing that issue, so that we can really get underneath it, because it's a recurring theme through this, and something I really want to get on top of, because I don't want it to continue being a recurring theme.
Right, hold up. In my personal life, I know of someone who would have
Eleanor,
to...
pull the microphone towards you.
I always think I'm loud enough. In my personal life, I know of people in the last 10 days, fortnight, that have had this happen to them. So it's not a first and second class, but I understand that you'd like people to come to you. What I'm hearing out there is people are more interested in rearranging their appointments than complaining to the health board that it's happened. So maybe we do need to ask for examples. The other thing I hear when I'm out and about, which worries me, is that apparently some departments are keeping lists of patients to be seen on Word documents or Excel sheets and not in any systemic way. That might have worked 10, 15, 20 years ago. I'm not sure it's where we should be now as a health board. And there is a cultural thing attached to that. So it is complex. I'm glad you're thinking about it. I'm reassured that you are, but I do think we need to move forward with pace on it.
Before Hugh comes in, one of my concerns about this is this plays out in our waiting times. This plays out in our waiting times. And one of the challenges, if people miss appointments because letters arrive at the wrong time, and we do know that people do, because it's 5%, broadly around 5%. You know, we have lots of people waiting to access these services. And if actually we are wasting these opportunities, and it may not always be our fault, it may be for other reasons, but what is within our gift, we should be compelled to do something about in order to reduce the length of time that people have to wait to receive some of these services. So that would be that's what drives me around the letters or the waiting process. Hugh, and then... Yes,
yeah, Chair, thank you. What seems at the surface to be a relatively simple challenge is complex, as Andrew's alluded to. We do have a programme of work, though, that will address this over coming months. So if I start with a programme that's been in existence now for a little while, which is our hybrid print and post programme, we know that letters that are using PAS, so WPAS, the main administration system we use, we know that when clinics are set up with that, we can siphon those letters into our hybrid print and post system, and it gives us greater assurance over the end-to-end process we've got. One challenge we've got there is we've begun that process with an opt-in basis for text updates, or text letters. What we think we need to do now is move into an opt-out process at some point with due consideration to needs of our patients. But I think that will help us make sure that we don't just use first class with next day delivery, but we can do same day delivery. And I think that would be a much more robust system for us to have. That's the first thing. The second thing is, I think there is a need for us to be looking at developing increasingly, again, this is work that's ongoing, centres of excellence, so that we consolidate our patient services and patient contacts into into a patient services centre. That's something that we've discussed as executives. It's a programme that is inherently relatively complex to deliver, but is one that I think will be a key part of our plan into the next financial year. We're getting some of the building blocks in place this year while we build into that plan. And it kind of leans into the strengths of the work that we've done with the Communications Hub, which has been a successful intervention. So yeah, lots of complexity, but where we do lean into our core systems, we can then adapt those and create that excellent approach we want in terms of patient communications.
Great, thank you. I mean, just a further point before I invite Mandy to comment is, I note further on in the agenda we're looking at the contract value for the outpatient service, and the cost of just sending letters detailed in that contract is just phenomenal, absolutely phenomenal, which begs the question, why are we doing that? You know, when we're in a situation where we have enormous financial challenges, we're actually still using conventional technologies that are costing us millions. So that's my challenge. And Mandy, and then I'll come to Chantal.
Yeah, I was going to raise it under the Improving Patient People Experience report, but there is a piece of work going on with the Communication Hub, so thanks for the comments about the Communication Hub, Hugh. Working with the waiting list teams in terms of how we respond to inquiries around waiting lists and appointments. So there is a piece of work going on around that in the meantime as we're working at expanding the Communication Hub.
And where will that go? Will that go to the Quality and Safety Committee?
Yeah, Quality and Safety Committee, yeah.
Okay, great. Thank you. Thank you, Mandy. Chantal.
I just wondered whether this is something that the digital transformation team could help in terms of prioritising, doing it all in a way that would make it a lot easier for individuals to be able to access the information on their phone and be able to not only make an appointment but also to reschedule their appointment. I know that this kind of system is in development in other health boards, and I just wondered whether that might be one of the priorities that we might want to look at in terms of managing this.
Yeah, very good point.
Yeah,
very good point.
absolutely.
Okay, I mean, we need to stay focused on this, as I'm sure that will happen, but we need to, the board needs to be assured that this work is underway and delivering the results that we would want. So we need to come back to this in the future. Anna's second question regarding theatre and policy.
Yeah, so I think there's a couple of issues with, and it's predominantly Glangwili that we've had the challenge in. They've had vacancies, they've had sickness, and it's the ability then to be able to provide that capacity. And what we've tended to do, and it plays into some of the performance conversation as well that is in the papers today, we've taken the view that with some of the emergency pressures we've got and our cancer waiting times, that we'd prioritise our theatre time then towards dealing with those pathways because of their impact on the overall system. That means that there are some routine cases that have been cancelled, and it's disproportionately impacted two specialties really, ENT and ophthalmology, who happen to have to do some of their elective work at the moment in Glangwili. The issue I think around policy that's being referred to is just some of the challenge they would perceive operationally with the necessary steps we've put in place to help have added oversight on agency and variable pay, and they're things that we've had to, Welsh Government have expected us to have a much tighter grip and control that. And the difficulty is that from a service perspective, their ideal scenario would be to be able to go out straight to agency at a far earlier stage in the process than we would probably think is always necessary, because there are always other routes to try and fill those shifts beforehand. So I think it's just the natural tension that we will have around trying to balance those two issues off. There'll always be a service perspective, and there'll be our perspective around how we need to kind of make sure we've got controls and processes in place that mean we aren't incurring unnecessary high cost variable pay. I know on specific instances though that through the processes we've got, an extension, a longer lead in time has been agreed with the service to enable them to go out to agency to try and fill those shifts, to try and mitigate some of that risk. So it hasn't been, so I think there was probably an issue at a point where there was a blanket view, and then they came back and there was a different position agreed for that specific service. So I think it's just always going to be one of those issues that operationally and from our perspective as an organisation, we're going to have to keep working on as we're trying to balance those sort of competing tensions and priorities. The other positive thing, though, is that we do know that we've been successful in terms of some of the recruitment overseas, in terms of bringing staff in. So I think we've got a period of 3 to 6 months that we need to manage, and then we'll hopefully see some improved stabilisation. But I think almost in the work environment we're in, it's an inevitable tension that we'll have to keep working with, and I'll have to keep liaising with the service on in terms of managing expectation.
You can come back, yes, please.
Thank you, and thanks for that explanation, Andrew. And I thought it would be something along those lines, but I suppose we're making a choice here, aren't we? Even if it's shift-to-shift basis or session-to-session basis, we're making a choice between the drive we have to reduce our temporary staffing expenditure, which is largely around agency staffing, and we know that doesn't represent good value for money for us in the sort of global sense, against increasing our theatre capacity that allows people who are waiting for planned procedures for a very long time, in some cases having a significant impact on their quality of life and in fact contributing to deterioration that may not be possible to regain, particularly for people who are frail and elderly. And those choices are being weighed up by us. And so I suppose it's important to be really transparent about that. I'm glad you said there is not a blanket rule, because that's an important thing to make known. It's not a case of, well, we can't have agency, therefore we can't do people's procedures. It is more nuanced and sophisticated than that. But where we are making those choices, we must be clear and transparent that that is what is going on, and not dress it up as anything else or make it more opaque than it should be. I think everyone understands the dilemmas, but let's be clear, we're making a choice, and in some respects we are standing in our own way here.
Of course. And there is no easy solution, is there? This is the territory between a right decision and a good decision inside this space. And it is always going to be difficult where we are trying to deliver against a number of priorities that occasionally are conflictual inside this space. But I think you're right, Anna, there's something about being open and transparent about that, even if it is a difficult decision for us to make. I'm going to come to Bill. Anne, you want to come in, and Chantal, I know you have a point you want to make? No? Fine? Okay. Fine. Michael wants to come in, and I'm not going to ask anymore because I know other people want to say something.
Thank you for your indulgence, Chair. Just one very simple point on exactly what Anna was just saying. I just wondered, because this is a very important point about the productivity in theatres, and I realise it's very challenging. Is there one of our subcommittees which would maybe look a little bit more on that to see how we can support and understand and deal? Because it's a fundamental issue, isn't it? If we're having this capacity gap, it flows into everything else. So I just wonder where we could, if we wanted to, look at that a bit further, is my point.
Well, let's not pick that up, because I'd like to come back to that when we look at staff, when we look at the policy kind of update and sickness absence. It might be something to think about then, because that's the root cause of some of this process, but we'll pick it up at that point. Great. Phil, and then Anne, and then we'll close the item.
Yeah, look, on the same theme, I suppose we've committed to get to a 104-week waiting target and a 52-week outpatient target, which we, in Q1, there was somewhere just over 140 patients. We didn't achieve that. In Q2, our expectation is we're much closer to zero on that. So I suppose some of the balance that we're trying to strike here, as you're describing, Anna, I think, is that how do we achieve that? Achieve what we said we would do in our annual plan, in the most effective way possible. And to go further than our 104-week target, of course, well, that isn't in our plan. But 104 weeks is a long wait for people. So people won't, I can understand the public not celebrating a 104-week wait. In fact, I would be very surprised if anybody would celebrate that, a wait until they have their treatment from referral. But that's the target we're trying to achieve, and even that is a challenge for us because we didn't quite achieve it in Q1. And it's not just whether we pay for additional shift, it's also generally the productivity in theatres, you know, start times, finish times, amount on our list, cancellations because people weren't ready for theatre. So there's a lot in whether theatres are productive. So I think there will be a discussion in the sort of PODCA paper, but there's a general issue of productivity. It's a key part of the enabling actions that Welsh Government have given us around planned care. And it's probably one of the areas we think we can make, there's scope for improvement on. So I do think, I take Joe's advice, I expect it's the Finance and Performance Committee that we would want to look at this, Michael, so it's a really good point. I'm grateful for you raising it. But there is a link here to when we get to the finance paper. You know, we are being asked to get to 24 million. So when we're trying to balance what we're going to achieve here, and your point about blanket bans on things, actually to get to 24 million, I mean, our plan to get to 31.5 million was a balance plan. To get to 24 million, it's difficult to get there without any consequences whatsoever. There's bound to be some sort of consequences of doing that, and we just need to be mindful of that as we go forwards.
Thank you. And last comment, Anne.
Thank you very much. I've been involved with the staff quite a lot.
Pull the microphone to you, Anne.
Thank you very much. I've been involved with the staff quite a lot, so I am hoping the objectives of 3 months is achievable. But the way it stands at the moment, it's great we've got staff now coming into theatre, but they're new. They have to be trained, so that takes quite a lot of time. And if we bring international nurses in, it's the same thing. They have to be trained to our way of working. So when we put a time frame of 3 months, I get a little bit anxious because the staff part of it who will be doing the work aren't in a good position at this present time to cover the theatres.
Good point, Anne. Andrew, last comment.
Yeah, just very quickly on that, because I think that, because just to make sure I'm clear. So in terms of the mitigating actions we've got, there is a plan that will stabilise the workforce position, probably through an insourcing approach that will at least make sure that we're not cancelling theatres unnecessarily, and we're doing that within the financial forecast for the care group to the end of the year to make sure we deliver what we said in our original plan. And obviously that's all subject to conversations later as well, I'm conscious of that. We've got the international recruitment as well that starts to move that forward, but I also know there's a further conversation that the Executive Director of Nursing has been leading from a Nurse Staffing Levels Act perspective around what the safe staffing levels for theatres should be. So I've been just a bit worried, I'm maybe slightly misled. I don't mean that we'll have fixed it sustainably in the next 3 to 6 months. We've got a plan that means over the next 3 to 6 months we will stabilise the position from where we've been over the first 4 or 5 months of the year. But there's more work to do to get to a really sustainable workforce model in the way that you're describing.
Thank you, Andrew.
Great, thank you. I'm going to close the item at this point. So can I ask that we collectively receive the update on the plan, as we have done. We haven't considered the response to Welsh Government's requirement for additional cost savings below 31.5 million. We'll look at that in the next item. It asked that we discuss the performance position against the de-escalation criteria. We haven't really discussed that in an undisciplined way. We discussed that in the previous item. It's probably my fault. And endorse the tracking of enabling actions across the 5 themes. And we haven't endorsed that, but I would say, Lee, that was very helpful and transparent in terms of being able to see that. I hope other people found that to be the same as well. Great, okay. Let us move to item 8, which is the financial report. Hugh.
Cadeirydd, diolch. I'll just briefly take us through the position and then open up to discussion. I think there's more value in the discussion than the presentation. If I start off just by referencing our run rate position, really positive position to be in at this stage. We did say we wanted to get to having de-risked our plan by the end of Q1. And in terms of our expenditure position in month, we're now at 2.5 million adverse to break even. Our plan was to get to 2.6 million. So that's a good position for us to be in terms of our actual in-month position. We needed to get to 2.6 million in order to provide assurance that by the end of the year we could get to 31.5 million. So that's positive. If I look at our forecast and our plan was to get to 31.5 million deficit. We've been able to reduce that, and I'm bringing that proposal to the board today. There are two elements to the reduction. So from 31.5 million, we can get to 30 million by taking out or deferring two investment proposals that we had in our plan. That's 1.5 million. That's mainly around the 24/7 model, so deferring that to begin towards the end of this year, which will have the impact then next year, and a degree of maintenance costs that we're looking to defer as well. So that's 1.5 million down. A further improvement of 2 million from further agency improvements that we've had that we weren't expecting, and medicines management improvements that we weren't expecting. That would take us to 28 million. But I need to recognise that we've had notification from Welsh Government that the funding we were due to receive to offset the impact of employers' national insurance contributions is short for the Health Board to the tune of about 2 million. So that offsets that position somewhat. So I'm bringing today a proposal that we reassess our forecast and provide assurance to government that we could get to 30 million at this stage. That, I think we would recognise, is an improvement on our plan, but certainly from the conversations we've had with Welsh Government, an insufficient improvement based on their expectations. Their expectation is that we would achieve 24 million, which was our outturn for last year. And I'll come back to that towards the end. The challenge that we've got is one of savings delivery. It's operationalising our savings. And I think that's clearly articulated in the paper. In order to provide assurance over the 31.5 million, we needed to deliver 44 million of savings. But in the books, as it were, at this stage, we've only got half of that identified. Now, the issue for us is that each month as we go through, we're mopping up areas of underspend. So we're able to mop up as we go through, which is how the in-month run rate is better than what that forecast suggests. But that does give us a challenge in terms of planning for resource allocation in a better way as an organisation. We need to work on, I guess, translating that in-month assurance we've now got into a prospective forecast assurance space, and that's work that we've got ongoing with the exec team. I've pulled together in Appendix 2 to the paper, which is on page 300, a summary of the areas of further potential improvement that we could make to our financial position that would support us in moving from 30 million to 24 million. Now, the list I've got there needed to just pass a very simple test in terms of presenting this to the board. Financially, are these costs that are sufficiently significant and sufficiently variable to be able to enact them between now and the end of the year and see that improvement? I've made no observation or test, really, on the adverse impact that this would have on service delivery, on quality, on safety, on equity. And I'm not asking the board for an approval on these at this stage. I'm asking the board to consider that these are the areas that are sufficiently liquid for us to look at further and put a process around quality impact assessment and equality impact assessment that would allow us to determine which areas here we would want to explore further to improve from the 30 million to 24 million. Chair, with that, I think I'll just open up to discussions.
Thank you, Hugh. Colleagues, thoughts or observations? Anne.
Thank you, Chair. My trade union colleagues have been looking at Annex 2, Appendix 2, sorry, and they're quite unhappy because it hasn't been through quality, it hasn't been through any committees, and they feel that the staff have worked really hard, and to try putting things like withdrawing overtime and stuff like that into a paper now would be derogatory for them. So they want it known that they're unhappy with the way this has been presented at this time.
Thank you, Anne. A point well made, and for us to bear in mind. I'm going to come to Maynard, then Eleanor. There's lots of other people, Chantal and Michael.
Okay, first comment is around savings generally. It was good to see that there is an additional 5 million. There is an additional 5 million being identified of recurring savings this month. We're just wondering what the state of those were. Are they potential? Are they things that are included in that list in Appendix 2 or otherwise? Because I'm conscious that, as the point you made, well, Hugh, that the later in the year we identify the savings, the less the impact in years going to be. Second point I wanted to make was on Appendix 2, but I think it's been better made by Anne, so I will not say any more on that. It's actually the impact on staff and things. Third point I wanted to make is quite a specific one in terms of, and it actually relates to an earlier discussion in terms of the theatre usage. We're down in terms of theatre capacity by 20%, and yet on consumables we've overspent by £0.8 million. If we were to go up to capacity, we increase the amount we're going to be spending on consumables. So it's that earlier discussion about balancing the delivering of the care against delivering our financial probity, our financial obligations. And I think that's quite a stark one, because in my head that's an extra £200,000 in a blink of an eye if we just get up to delivering what we said we could deliver in theatres. I'm also concerned on the same slide that the second biggest area of overspend is on there's a legal services underspend, but dental contracts. And again, it's another area, and we've got a paper on it later in the agenda, so I won't labour that point. So we are counting as savings or overexpending in an area where we know we're not delivering service.
Fine, which I think accounts for the fact that much of our cost savings is usually, non-recurrent revenue that we're not spending, we're managing not to spend. But the consequences of that are quite significant. There's a cost. There's a cost to overspending, there's a cost to not spending enough, and we need to be mindful of that. Thank you, Maynard. Eleanor.
Thank you. Diolch, Cadeirydd. My question is not a Hugh question, not a finance director question, but I think it's about finance, operations and strategic thinking. There's loads of moving parts at the moment, the fragile services, the CSP, we absolutely have to deal with the financial deficit we have. There is no doubt about that. What we do have, though, is a vision for what we'd like to do for the future, about more people treated in communities, about nearer where they live, about moving to that social model for health. I want to be assured that the strategic thinking is going on about our services in terms of finance and operations, that will move us towards that. What I'm hearing is the hugely hard work that people are putting in to deal with the financial deficit, and I commend everybody for that. What I'm not hearing is how we move from here to where we need to be, and I appreciate that is really difficult when we're in the middle of it, but that's the assurance I'm seeking.
Okay, so that feels to me as if it's a broader systemic thing rather than just cost saving in a conventional way. I think we all share your anxiety in respect of that. Can I come to Chantal?
Thank you, Chair. I think I echo both what Menard and Eleanor have said, and I was just wondering whether how and who assesses whether those financial mitigation measures that we're putting into place are actually aspirational, or whether they are something that we can realize, and whether they are sustainable long term. Because it looks like to me, when here you were talking about, saving things on meds, for example, that may not be sustainable. It might be that that goes up in the future as well. But it's whether we have that kind of look as to the things that we're doing that will be sustainable long term.
Which is about how we control our expenditure. I absolutely agree with you on that. Michael.
Yes, thank you, Chair. It's just on the savings gap issue, which we're already about to enter quarter 2, and the savings gap issue is prevalent now. So, Hugh, I just wondered what progress do we think we can make on this by? We'll have a finance committee meeting end of next month. What progress can we make? Because we're going to have to make some progress on this. What do you think is the position we're going to be in by the finance committee meeting, and by this time the next board meeting?
Good question. Anybody else have any other questions before we move on? Lisa.
Thank you. Mine's more a comment than a question. So I just wanted to advise you all that I did meet with our trade union representatives from each of our counties earlier this week to go through the appendix, and did recognise that our normal practice would be to go through our partnership forums and our regular conversations. So I have given a commitment that no decisions have been made, and that I will be working with them and involving them as we progress looking into each of those schemes.
Great. I mean, Hugh did caveat what he said by saying they are just a list of things. They are not endorsed. They are not agreed. They are things that you have to put on the list when you are considering how you move towards what will be a very difficult cost-saving period if you have to make those. That doesn't mean for a moment that we would be moving in that area, and it would need the necessary level of scrutiny at subcommittee level before we even ventured towards that space. Just reinforce that. I was going to invite you to say a few words. Hugh, I don't know if you want to come back first.
Happy to, yes. I'm relieved that Lisa didn't have a question because I've run out of page. So I will go through and respond hopefully to all of your questions. And if I start off with trade union colleagues, of course we need to be working with staff side colleagues. The reason for the articulation of this list is for the board to be aware of the scale in categories, for the board to be aware of the level of scrutiny and I think the available areas for us to review at this stage, given we are in month 4 now and the limited amount of time we've got within the year. You end up inevitably going at the areas which are big, well of course they are going to affect our staff, and variable. So of course you end up with overtime, variable pay as areas to scrutinise. So that's the rationale for it. We need to wrap a quality and equality impact assessment process around this, and I'll come back to how we do that towards the tail end of my response now. But I do want us to make sure that as a board we are transparent in the choices that we're taking and in the options that we're considering. And I think ultimately I'd prefer to err on the side of transparency, recognising that we need to go through a process of engaging with colleagues as well. Secondly, Maynard, your questions around duplication. There may well be a degree of duplication between savings. Inevitably, there will be. We are all looking at a limited pond within which we are all fishing for opportunities. So there may well be a degree of duplication. We'll obviously make sure that in presenting the end result, that duplication as far as possible is managed out. There has been an improvement in savings between month 2 and month 3, and a further improvement since the month 3 position. So we had 22 million, we're now up to about 23.5 million identified of savings that are green and amber. So that's positive, but clearly the scale requires it to be much bigger. The disconnect between theatre utilisation and consumables, this isn't a perfect science, of course it isn't, and I know you recognise that. There obviously is a case mix issue as well, which impacts that, and a dependency on how much we outsource versus how much we do in-house. But that's something that the team within Planned and Specialist Care in particular are very sighted on. Dental contract is an area we know we don't want to underspend against. We know we want to make sure we fully utilise the dental allocation we've got. In fact, it's a ring-fenced allocation. So it's not something we've taken a conscious decision to delay on. These are naturally occurring delays in contract handovers and in managing that contractual position. Now, there is an option within Appendix 2 to consider a delay, but that would be a decision that would need to come back to the board with a full quality impact assessment. Elena, absolutely, Vice Chair. In terms of moving parts, there are a number of moving parts. Just to try and bring that together, I've presented to the executive team a roadmap that would consider all of the issues that you've alluded to and provide us with a 3-year recovery trajectory for the organisation. That needs finessing, and that needs to come back to the board as part of next year's planning round. I anticipate that coming back to board in November as part of a staging post to indicate the limiting factors within our planning round for next year. We're also, I'm exploring with colleagues in Swansea Bay using the STAR technique, so the socio-technical allocation of resources approach to providing greater assurance of allocative value across our organisations, how we resource the organisation in a more strategic way. We'll be doing that with colleagues in Swansea Bay. Chantal, in terms of how and who, naturally this is within the executive team, and each executive team member as budget managers will be taking their own leadership role within their teams in bringing through those opportunities. These opportunities have been cascaded out already into the executive team and deputies to consider and to work up what quality impact assessments need to be assessed. The timetable for that is to bring something back to the executive by the 15th of August, then to bring that into a paper, quite short turnaround, into Finance and Performance Committee for the 19th of August, and then to bring that back to board in September, which will give us an indication of, I guess, the scale of the opportunity that we can then come around and deliver against, which will go into Welsh Government as part of our September submission. And then, Michael, hopefully, I think that kind of answers your question as well, unless there's a missing piece in your belief. We will bring that back to Finance and Performance Committee. We'll provide assurance, scrutiny in that committee to provide assurance to that board conversation that we'll need to have.
Very good, thank you. Rodri.
So just to understand, Hugh, so for the September board, this will be a decision paper because most of these are associated timescales kicking from August till March. We know what the value of the saving is, so really there would be a decision paper on some of these, most probably in September.
Yeah, so the total list here comes to 22.5 million. So clearly not all of these would need to deliver at the level that we've outlined. We need 6 million. So we'd bring back something then that pulls that together, if that is possible. I don't want to prejudge the quality and equality impact assessment, because as Phil alluded to, we spent an awful long time as a board considering what was achievable to get down to 31.5 million. this is a significant additional requirement for the board to take. I struggle to see how that can be achieved without having some detrimental impact, but then it'll be about balancing the totality of those impacts in that board discussion.
Because it's 6 weeks we've got, and it's just kind of, it's a time scale is short, but then thank you for the clarity.
Great. Anna.
Yeah, I just wanted to make a quick comment, really, in support of our Director of Finance. Which is a rare moment, Hugh, so soak it up. I think Hugh was very careful to pitch this Appendix 2 to us with some very tight parameters around it, which I interpret as being him saying there is no sophistication in this list. It is basically an accounting exercise based only on the liquidity of these opportunities. It is nothing more than that. And I'm casting my mind back to a number of conversations over the last couple of years in various different settings when I have been amongst a number of IMs who've said to the executive team, we would like to see your workings. Don't bring us a polished product which you then just want us to rubber stamp, because we haven't seen the preceding process that you have been through. So don't just bring us a censored version, because we can't get our heads around what you've been through and the choices you've made to get us to that point. So when the exec do show up with a list that is showing their workings, I think we really need to acknowledge that is a response to what we have been encouraging over conversations over the last couple of years. And we all have to kind of understand the uncertainty and the discomfort that it produces, but we ask to join that discomfort with our exec colleagues, and we must now be prepared to live with that, or indeed change our request to our exec team.
Thank you for the clarity. Thank you, Anna. Mandy, do you want to come in?
Yeah, just quickly. Thanks, Anna. And I completely agree with the QIA process and quality perspective, because there are, and obviously welcome the conversation around the professional issues that some of the proposals raised.
Of course. Thank you very much. Phil's going to say something, but I'll just share some thoughts, and it partly emanates from what Eleanor's said. You don't have to penetrate very far into this organisation to understand that staff feel that it's all about money. So increasingly the narrative is you're just trying to save money. And invariably, we do need to become sustainable. It's been a message that I shared the moment I became chair, and it's one that I will continue to make. We have to become sustainable as an organisation. But the challenges are that the difference between becoming sustainable and people thinking we're just about money are enormous inside that space, because we're not just about money. We're about value-based healthcare. We're about ensuring that we make the best possible use of our resources, and that our clinicians and our staff use that knowledge and expertise to deliver the very best of healthcare. It does feel to me, one of my anxieties has been that such is our drive towards reducing our costs, that we have, we work on the basis of across the board cut to everybody and everything. And I think, Hugh, you've just alluded to the fact that we need to sophisticate our approach to how we think about reducing our costs, because there are some areas we need to continue to invest in, we need to fortify, we need to grow, and there's other areas that we need to decommission. And actually, we can recognise that it's not delivering the value that we would want. We need to be braver inside this space, so we need to find a way in which we can start to come up with a much more mature approach to reducing our costs. Now, I don't think that's a big step, because I think this organisation is already starting to do that. It's already seeing the logic of that. But I think that's the road we need to go down. One of my deep concerns, and we only have to look at the history of NHS organisations saving money in a slavish way, is that something goes wrong. At some point, there will be a safety issue, something will go wrong, and patients will experience a detriment as a consequence of this. We've got to avoid that situation. We've got to be good enough at managing our financial model and sustainability in a way that we don't take unnecessary risks with patient safety or care. That's our ambition. It's much more complex than trying to save money. It's about also ensuring that we save lives at the same time. That's our primary function inside this space. So I want us to think much more about how do we create a more sophisticated model that allows us to deliver value-based healthcare, and more importantly, create an intrinsic regard for how important it is to use our resources well, rather than an extrinsic, no, you can't spend that money because the money's not there. We want our staff to think intrinsically about where they can exercise choice and save money, or where they can deliver better value, how they can do that on a day-to-day basis, because that is our long-term solution to resolving our financial position. The work that the organisation's undertaken over the last 12 months has been truly heroic. We have saved a lot of money, and staff have worked extremely hard to get us into that position. The leap, the mind shift we need to make now is much more to understanding how do we start to create new service models and values around the things that we're delivering to achieve the outcomes we need to, but at a value that best reflects the resource base that we're working with. Chair, Phil.
Thank you. Diolch Cadeirydd. Well, you've much more eloquently made some of the points that were going through my mind, actually. So I think just the context of this, we just need to remember that we spent since October time constructing what we felt was a balanced plan, which when we produced it at the end of March, had significant risk within it. So we were aiming to get to our target control total, which was part of our TI de-escalation criteria of £31.5 million deficit. And within that, there was significant risk. And we agreed as a board that we would spend the first quarter de-risking that plan, which we've been successful in doing. In fact, we've overachieved on that, because without the national insurance issue, we would be suggesting reporting 28 million, which would be only 4 million away from the 24 million. And yet, you know, we've even managed to mitigate that. And so we're already recommending to board that we change our forecast to 30 million, another 1.5 million less than our target control total. However, our outturn was 24 million last year, and the CABSEC has been absolutely crystal clear in his expectation that we get back to our outturn last year of 24 million. That's something that wasn't set out right at the start of the year. That's been through quarter one that we've received that expectation. So we are responding to that, I suppose, in the most professional way we can. And Anna, you've made the point I was going to make better than I could have done, that we're bringing this to you earlier. It's not a 6 million list. It's a much bigger list. And for the staff, I'm really sorry to our trade union colleagues and staff, because this is not the way we would normally want to do things. It's something where we're under significant time pressure, and we really do want to work with staff, and we do want to, even in that last 6 million, to get back to 24 million. We really do want to consider the impact on staff. In fact, we want to come at it with a deep quality impact assessment and equality impact assessment that does think about impacts on staff well-being, because we expect a huge amount of our staff, even with what we've put in the plan at the moment. And we really do need to balance performance, quality, safety, equity, staff well-being, as well as finance. But as others have said, we need to make sure that we don't do something that disrupts our progress for the future, because we could do something that actually affects our sustainability for the next 3 years, because this is quite tricky for us. And we need to produce our answer to Welsh Government by, I understand, the 11th of September. And so we, as Hugh has described, we have a timeline for that through the Finance and Performance Committee, but we are seeking dates for an extra board, I think in the first week of September, so that we can collect together again to consider where we've got to with those quality impact assessment. And it's likely there will be decisions for us to make, and maybe even options, I suppose. So, but look, I think on the savings, and on your point about financial modelling, at the moment, as we said last year, our non-recurrent savings are generally from the areas that we would like to allocate more resource to, like dental, public health, OD, mental health. They're all the areas where we'd want to allocate more resource to. So I would see that as part of the solution to your ask. I know Hugh is working on a 3-year financial plan closely with Lee. We are going to need to see the fruits of that later on this calendar year. But I'm sure there will be plenty of debate as we bring that to the board. We are being asked by Welsh Government about the profiling of our savings through the year, because Welsh Government see, when you look at our chart, I've forgotten the page it was on, it shows that our savings for the first 3 months are high because of Hugh's point that we're mopping up the non-recurrent savings. And there's almost an expect from what Welsh Government see that the rest of our savings profile is much lower for the rest of the year, whereas we know that there will be non-recurrent savings. So we are trying to respond to that question, because for the public and Welsh Government, they could be worried about our savings profile. So we are looking at that. But I really appreciate this discussion, but clearly we're going to have a lot more discussion through Exec Team, Finance and Performance Committee, and another board meeting, hopefully in early September.
Thank you, Phil. So, in order to close the item, can we approve the proposal to change the Health Board's financial plan deficit to 30 million from a revised savings target? Great, okay. Seek assurance on progress of savings actions to bridge the recurrent and non-recurrent savings gap from those executive portfolios that have yet to identify their full target. Yep. Seek assurance there are sufficiently robust plans in place to eliminate the use of off-contract agency and reliance on healthcare support worker agency by the deadlines set in the ministerial priorities. Yep, great. Okay. Discuss and consider the further choices and actions being proposed to achieve additional improvements in the financial deficit trajectory beyond the proposed 30 million, following the latest feedback received from Welsh Government stating that the Health Board's annual plan is not supportable or acceptable. I think we've just had a fairly healthy airing of that. And acknowledge that an underlying deficit assessment has been undertaken, and this will only be reduced via robust recurrent savings and delivery improvements. I think we're very much in that space, aren't we? Okay, thank you very much. Hugh, I'm going to continue with you, and we're going to now move to the Integrated Performance Assurance Report.
Yeah, diolch Cadeirydd. So I'll just direct members to the summary SBAR, and page 3 of the SBAR has a 3A's assessment for our position. A few things to draw out for the committee's, for the board's attention even. At the end of June, naturally urgent emergency care is our most challenged area. Ambulance handovers in particular at Llangwili and Withybush continue to be demonstrate the most challenge for us, and that of course has had a detrimental impact on patient experience and performance, which we know as a board is not an acceptable position for us. We'll hear later about the Accelerated Transformation Programme for UEC, and that's on the agenda. The number of delayed discharges continues to be a challenge for us in impacting on patient flow, and that's something that I know is receiving significant scrutiny. Performance within our eye care patients has been considerably below the target that we had of 95% over 3 years. We're working on options, and I'm sure Andrew will say more about this, to work on that at a regional level. We're seeing a very worrying trend in psychological therapies within mental health as well. Our performance had improved last year following introduction of group sessions, but we've seen a decline now for the 7th consecutive month. And our performance within neurodevelopmental services continues to be significantly below the target. ASD, a particular challenge for us, with demand far outstripping the capacity we have. Just a couple of other areas. The position in C. diff is also a very significant concern. I know a concern for us and a concern for Welsh Government, and I'm sure Mandy will have something to say about that. But I'm pleased to report improvements within our cancer performance, where we achieved 66% in May, and that is hopefully will be an area that we will maintain and build on improvement. A couple of things I wanted to say as well about, we've got an escalation summary within the report as well for board members to see the work that's happened across each domain and across each clinical care group and executive function. The two clinical care groups with the most significant number of challenges would be community and integrated medicine, and the complexity of that care group in particular. The performance challenges are highlighted very clearly in the IPAR, and within planned and specialist care, given some of the weights that we've experienced and some of the staffing issues we've already discussed in theatres, but also in critical care. So, Chair, with that, happy to open to discussion.
Colleagues, questions or Maynard?
First to put my hand up. Yeah, it's a couple of... Thank you, Mark. Specific points. One of the areas mentioned in the most recent letter from the CABSEC was about vaccinations and achieving our targets there. And yet those are in alert and advised categories within the IPAR. So I'm just wondering, some of this is, I think, the growing vaccine hesitancy that we're seeing in the public. And I'm just wondering, how do we combat that vaccine hesitancy, and how do we achieve the targets on COVID? In particular, I have friends who are saying they're not going to bother with the COVID vaccine anymore. Second point was on dental. There's a couple of lines at the bottom of the first table on dental, and the data there is 4 years out of date. So I'm just wondering why we don't have any more accurate data there. And also very concerned about the number of high risks that we have, worryingly high. I'll leave it there.
Great, okay, thank you, Maynard. Michael.
Thank you, Chair. Hugh, something, as you'll be well aware, we're trying to look at in Finance Performance Committee is looking at what are the kind of actions to try to improve, and trying to measure the effectiveness and timeliness of those. So, in a way, that's not fully captured in this report. But firstly, I want to assure the rest of the board that that's what we're looking at in Finance and Performance Committee. But are we going to be able to see some of the fruits of that? Well, not the fruits of the outcomes, but that kind of analysis in the next F&P committee to try and understand what steps we are taking and what impact those steps are having.
Great, okay. Colleagues, any other thoughts? Eleanor.
I just wondered if we could have any rationale why the C. diff cases are going up again. I'm channeling my inner Dallas, a previous member of the board, who would have asked about it.
Okay, great. Bethan, I'm going to come to you on the question of vaccination, but more broadly, let's just, Rodri.
Just perhaps, Lisa, sickness is slightly reduced here, but it's still 57 whole-time equivalents. Perhaps just to have a brief idea of kind of where are we at with this now.
Ewan.
Yeah, no, thank you. Diolch, Hugh, for the report. I know this report was written before information which has been published today from Swansea Bay, which is interesting in terms of reading the differences they've made in terms of 127% improvement on their ambulance waiting times at A&E in Morriston. And they've also reported in terms of improvements for waiting times for patients within A&E there as well. And what's interesting to note as well is they've also seen in terms of their staff an improvement in terms of staff kind of appreciation and welfare in terms of their coming into work and what they feel they're being supported with. Now, there is the challenge in terms of, well, in the summer months, there may be less people coming through the door due to winter pressures. But actually, the figures published today show they've actually been dealing with more people in July than they actually had in January. So I know colleagues around the table work very closely with our colleagues across other health boards across Wales. But it's interesting that these figures that have come out today and have been published may be something that perhaps could be something that we now look into in more detail to help our performance across our health board.
Yeah, and I think we ought to congratulate Swansea Bay. It's a fantastic achievement and, you know, absolutely attributable to the great work they've put into this and to the people who are delivering it. Very, very good. Okay, so in terms of response, Hugh, do you want to come back first?
If I, maybe easier if I kind of allocate out then.
Yeah.
Maynard, in terms of vaccine hesitancy, I may ask Bethan to comment on that in the first instance. But your second question on dental information and the disconnect, obviously the information is more in the public health space, so it's difficult to get that data on a regular basis, and that's the challenge that we've got. Obviously, our performance information, we have up-to-date performance information, but and certainly when it comes to contractual delivery, but in terms of the population coverage, that's more challenging for us, and is a challenge that we've got across a number of public health metrics. So maybe Bethan in the first instance, Chair.
Great.
Okay.
Bethan.
Thanks, Chair. Yes, it's been worrying us for some time in terms of our vaccine uptake, and when you look at the COVID programmes, you can see that general decline. We are still awaiting our final spring booster figures, but we had reached 39% when we did a targeted approach in terms of mop-ups and offers and to see what we can do, but we don't have that time in spring because there's such a small window to do so. Some of the feedback from the autumn programme, and certainly with flu also from our primary care contractors, is this lack of interest in COVID and whether that's having an impact on other vaccine programmes. When you look at vaccines across the board though and our other uptakes, yes, hesitancy is possibly a factor, but it's not the sole factor, and we've got to improve access and the offer, the invite, and how we ensure that we reach everybody in an equitable way. And certainly, when you look at our school programmes, children are coming forward in larger volumes. MRMR, for example, they catch up in terms of by the time that children are reaching 15, 16. So there is something that we need to do collectively, and we're looking to do collectively with primary care around how we address those difficult areas, how we work as a team across the health board team that we now have and the primary care contractors to reach those individuals, offer other opportunities, maybe in the evenings, other appointments that make that easier for parents and adults to attend after work. We're also working with Public Health Wales on the messaging and the behavioural science unit there on how we best reach our community. We've had quite a good response from the leaflet drop that we made. We sent leaflets to over 197,000 homes on check your vaccine status, and we have had people ring. The general trend at the minute, they're not the people who are missing vaccinations, so we're trying to see if we can follow that up then.
That's very helpful. Actually, I think in the the board assurance framework, we do look at vaccination there, which seems to be quite high. Under 5 vaccination, to my recollection, it was around 85%.
Yeah, uptake. The target is 95%. The last quarter, well, I say last quarter, Public Health Wales data is behind those quarters. In January, we had reached 90%, and it's now to 85%. So it does fluctuate.
Right, okay.
What we're trying to do is see if we can get it past that. The changes in the childhood immunisation schedules brings MMR vaccine into up to 18 months instead of 3 years in January 2026. There's a belief that may change and improve that uptake, but we need to monitor really closely the preschool booster then, which is still at the 3 years, 4 months.
Thank you very much.
Chair, thank you. Michael asked a question around the, I guess, providing clarity of the link between the scrutiny and assurance process that's going on in finance and performance into the escalation process. I think we just missed the cycle. There is more work that we need to do. I'm always quite vigilant of spuddling, I think is the word that NHS Improvement use, where there's an awful lot of words produced in a report, but doesn't necessarily get at the key action that needs to be taken to unlock the improvement needed. So in any iteration to this report, we'll be quite guarded against that to make sure it's very focused. And I think that's the direction of travel that you've clearly articulated for us to follow within FMP. And I think it's a good discipline for us to follow. So we'll bring that into future reports. Roger asked a question around sickness. I don't know if I just hand over to Lisa on sickness.
Yeah, thank you. So we are doing some work with our trade union representatives around long-term sickness. So you can see on the iPad that short-term sickness, which tends to be the problematic area, is relatively low compared to long-term sickness. And what we are hearing are a number of people who are too unwell to return to work in their current job, but they may well be well enough to do an alternative job. And therefore, we're setting up a task and finish group with our trade union representatives around how we identify those individuals who want to work and are able to work, but not in their substantive role, and how we can match them with positions in other directorates, because managers will only look at their service and their staff. So a meeting's been arranged at the moment so we can have a look at what we can specifically do around long-term sickness absence.
Great, thank you.
Great, Chair. And I think the last question was from Yuan on UEC and A&E, and yeah, I absolutely echo the congratulations to colleagues in Swansea for their work. But I know we'll have more on this later, so I'll hand over to Andrew.
Right, Andrew, I'm going to hold you back on this one. Keep your powder dry, because when we come to the UEC conversation a little later on, you might want to use that. I'll invite Phil to say something.
C. diff question.
Oh, C. diff, sorry, yes.
I don't think I can add any more than is in the paper, Eleanor, other than the Bwrdd being in a hospital as opposed to community links with the fact that we are lapsing in hand hygiene and beer below the elbow, and maybe that's contributing to it. So, but yeah, happy to go back and look at it and bring anything more back.
It has gone up again.
Okay, can I just bring in James at this point?
Thank you, Chair. I just wondered if I could maybe address some of the concerns around C. diff and the alert that we got in the Quality Safety Experience Committee section of the paper later, because I think I can tie some of the concerns around standards of cleanliness along with the concerns around that. Thank you.
Great, okay. Yes, please.
Good. On urgent emergency care in Swansea Bay, yeah, I would echo the congratulations. Excellent, the progress that Swansea Bay have made on this. And we've known about this for some time, actually, just to reassure the board. Something we're connecting with. I know Andrew's connecting and his team are connecting with Swansea Bay over, and indeed Cwmtaf, University Health Board and Cardiff and Vale. They've all made some significant progress, and our clinicians are also connecting with them. So we've asked for an update at the Regional Joint Committee. We've asked them to do a presentation. For those IMs who attend the Regional Joint Committee, you'll see that update, which I think will be useful for all of us to see. But we'll hear more later on urgent emergency care, because we do need to make some significant progress.
Great. Thank you very much. Hugh, thank you very much for the item. I echo Michael's point, which is that where we can see underperformance against a number of targets, what we really need to be assured of that there are plans, impactful pieces of work in place to improve the performance of those areas. What worries me is that we do see there's a pattern. There's a pattern to this, and it sometimes incorporates a whole series of missed targets or priorities. So I think we need assurance as a board, and probably through Finance and Planning Committee, that there is in place architecture to improve the way in which these services are operating. Great, okay. if that's all we're going to discuss on this item, can I just take us to just the recommendation, which is it was just to discuss the IPAR and to seek assurance on the operational delivery of mitigating actions, improve performance in the areas that have been categorised as alert. Is everybody comfortable with that? Great. Okay. I'm going to, at this point, I'm going to suggest we take a break. We can take a 10-minute break for some refreshments, and then we'll reconvene around about 25 to 12. Thank you. Thank you, everybody, for returning from your refreshment break so quickly. I'm conscious that we've got a number of items on the agenda. This is usually quite the meaty section. Having said that, the last section was pretty meaty as well. So we'll press on. If I could take us to item 10, improving people and community experience. Mandy, I'm presuming you're speaking on Sean's behalf.
Yes, I am. Yes, thank you, Chair. The report covers the period between April and May 2025, and it also provides an end-of-year summary for 2024-25. I think we can see that the introduction of the People's Experience Framework and the All Wales Survey has definitely given us information that we can now, which has helped us to be more analytical around the reports, but we also recognise that the new framework and the new survey only came out in April. This will develop and we'll get more data over the coming months, and we'll be able to capture more about patient satisfaction from those surveys. But we are encouraged by the Health Board's response, which apparently at 15% is excellent. We're also able to build a picture around further analysis in relation to patient demographics from these surveys, and we're already seeing some informative findings, particularly in relation to minority ethnic groups in terms of satisfaction and accessibility issues for younger people and people with disabilities. And we'll continue to take significant actions around that data and explore that data alongside some work that's going on an All Wales level, and also from surveys that are currently being piloted for paediatrics and maternity. And the report provides some more detail around primary care patient experience, following on from the last report where we reported on managed practices. We've now got the independent practices. Themes from complaints, unfortunately, are consistent, and we provided further information in this report in relation to communication. And the main issues around communication are engage with families, with patients in decision making, communication with families, particularly communication with families and language choices, but also multidisciplinary working, particularly in relation to discharge planning, cancer diagnosis and end-of-life care. And this will be subject to a really detailed, in-depth discussion at the next Listening and Learning Committee, and that will be taken back to QSEC. So overall, we are seeing a steady increase in the number of inquiries and concerns and complaints. And as I spoke earlier about, we're doing a specific piece of work in relation to the number of inquiries for everything related to waiting lists. And that review will continue between the Waiting List Support Service and Communication Hub and the PALS team in terms of how we respond and how we manage those more appropriately, which will hopefully inform any future work around appointment letters and that going forward. And there's also been some initial work to better understand the areas with the highest volume of concerns in relation to their activity. There is more work needed on that to make sure that we've got consistent and accurate measurement, but initial work does demonstrate that the highest number of complaints are in the areas with the highest number of pressures and are linked to our clinical services plan. Disappointingly, we've seen a reduction in 30-day responses, so our performance looks disappointing, but especially as we've made some significant improvements in that area. But we think what it's related to is that we've got an increased emphasis on early resolution, which is resulting in the more complex cases being managed through the PTR process. And then finally, just to say that there were no concerns to be reported this time in relation to the public service ombudsman. Happy to take questions.
Diolch, Mandy. Colleagues, Sarah and then Chantal and then Michael.
Thank you, Chair. So two questions, really. Firstly, around the timeliness of the data. Obviously, we're looking at April and May data. It would be much more useful to see something more timely if possible. And also, I'd be really interested to understand not just the themes, but how is this work informing other pieces of work that we're doing? What are we doing with all of this information? It's great to understand some of the early things that are coming through. My question is a so what question. What difference is this actually making?
Great, okay, thank you. Chantal?
So, thank you, Mandy, for the report. And my question is a little bit of an extension of what you've asked. And it's in relation to, I think, as part and parcel of the Listening and Learning Committee, the theme of poor communication has been something that's been constant as part and parcel of that. And I know that's been discussed, that was going to be taken up by the education department in order to try to see what measures can we put into place in order to upskill clinical staff in particular, in order for that we can see some progress in terms of better communication with patients. But I'm not sure where we are at with that.
Okay. Thank you, Chantal. Michael.
Yeah, sorry, Chair. It's almost the same kind of theme, and I compliment the fullness of the report, but yeah, it's the so what question, because you actually said about feedback is giving you is going to provoke significant action. So the interesting thing is where in due course do we see those significant actions playing out? So I think that's the theme of our questions, Chair. Yeah.
Great. And before I come back to you, Mandy, Lisa, and then Eleanor.
Thank you. So I just wanted to raise the point about it's great to see the demographic information in here, and particularly for the Equality Task Force. It'd be really good to start to work with you around that to see exactly what the experience of our patients is. So thank you.
Yeah, I would echo that. I felt it started the journey. There's more we can do inside that space, more ways in which we can become much more granular, understanding what I think is often a non-white experience around healthcare. We need to do a lot more work in that area. Mandy.
Yeah, and that in a way answers that question. That's where we need to be using the data to make the changes that we know are needed, and using the patient experience data and the feedback we get from patients in other pieces of work. We do sort of use it to inform some quality improvement, and what I suggest we do is ask Louise to bring a report back next time that sort of tries to explore where the information's being used and how we can demonstrate what a difference it's making to.
Great. I think I'm going to come to Eleanor, but we absolutely need assurance that when we are identifying complaints, there are patterns, and you've already identified some of the reconciliations between the correlations between services under pressure and complaints. But I suspect we might find more as we deepen our understanding of the nature of those complaints in that area. We do need to know that it isn't just a data collection exercise, that actually we're doing something useful with it. Sarah's first question was the delay in the data, because it feels to me as well, the other thing is if something has gone wrong, essentially being sensitized to that thing that's gone wrong and doing something about it is time significant. So if it's 6 months ago, then people would have forgotten it. If it's a month ago or 3 weeks ago, people will remember that and more closely identify with it. So there is something about the data, the relevance and the timeliness of the data to be able to read this well.
Yeah, and I did ask that question when I was pulling my, reading the report. Was when do we get the data? And there is a month's lag in getting the data, particularly from the patient experience report, and also the 30-day response rate in terms of where the complaint has gone adds to that. So we are looking at about a month. So we're not that. June's data could June's data be included in this? Is the question. Yeah.
It's about the rhythm, but my sense is they should probably be able to use with technologies, that data should be immediately available rather than have to wait a month to process it. Eleanor.
Thank you, Chair. Diolch Cadeirydd. You've raised two of the 3 points I was going to make. One was around the EDI, the importance of that in this and getting that. The second was about the use of technology or AI. Is there a better way that we can be collating this data and slicing it in different ways to give us a better feel? Because the sense I'm getting out and about, we're reporting an improvement or de-escalation, which is great progress, doesn't feel like it when they're out there. And nobody comes to work to do a poor day's job or to be rude to somebody. Well, 99.9% of people don't. And I'm just wondering if some of the stresses and strains in our organisation at the moment are being reflected in the comments around rudeness, not listening. Can you get underneath this to tell those particular areas where there are more or less of those complaints being made, so we can target improvement rather than just a blanket improvement?
Yeah.
Diolch.
It does feel to me, that's exactly where I was going to go. So it feels to me this trying to link the data with action or remediation and very localised remediation. I think it's a good point made, Anna. Anna, that should come through Quality and Safety and Experience Committee. It needs to be scrutinised at that level, in my view, and we need to seek assurance at the board through the committee that this work is being addressed. Great. Okay. Thank you for that. Thank you, Mandy. Did you?
Well, we didn't quite on the point about AI and tech, which you've both sort of urged us to look at. I think the point about AI and tech that you've both urged us to look at. I think, Hugh, perhaps we could ask also that. I mean, it would need to come through Quality Safety Committee because the fruits of that would come through there, but perhaps through Hugh and Sharon they could consider whether that's possible.
Possibly policy as well.
It's just the data, the frequency and the timeliness of the data.
It will be possible. The question is one of prioritisation, I think, more than whether it's possible, and that's something that we need to consider as part of a planning approach for next year.
Okay.
My understanding is they are using AI to some degree within the complaints team, but I don't know any detail in terms of identifying the themes.
Okay, let's investigate that further to have a sense of what might be achievable in that space.
And bring it back.
That would be very helpful. Thank you. Okay, I'm going to move us on to our next item. Well, first of all, we were asked to receive the Improving Patient Experience Report for assurance, and thank you, Joe, we have done. Can I move us to item 11, which is the Board Assurance Framework? I'm going to turn to Phil.
And I'm going to turn to Joe, because Joe is going to take this report.
Thank you, Chair. So I'm not going to go through the BAP in detail, because I think we've covered a lot of this in the items this morning, in particular the performance report. But just so members are aware, we have looked at the planning objectives and aligned those to our new strategic objectives, and these have all been reviewed since the previous board when we discussed this in March 2025. And all the committees have had a progress report on delivery of their planning objectives as well, but we recognise that these are still under development and will be brought back to the next round of committees. So just the three things to call out really is that the majority of the planning objectives are on track, with the exception of planned care and the estates plan, which are behind. And it's pleasing to see the planning objective 9 on digital is now complete, Chair. So if there's any questions, it'll be from support with my executive colleagues.
Thank you. Colleagues, are you comfortable with that? Great, okay. Thank you. Thank you, Phil. Thank you, Joe. And we're assured. Thank you for that. Could I move us to item 12 and refreshing the Healthier Mid-West Wales strategy? Lee.
Thank you, Chair. So the paper provides an update on the work being done to progress the strategy refresh that we've talked about a number of times as a board, and provides a specific focus on population and partnership working and digital alongside those updates. So within the updates, I'll just touch briefly on some of the key points that we're providing some further information on today. So we have included the draft design principles, which board members will recall we recently discussed at a board seminar, and we provide an update on the engagement work underway. To the question that we posed, you'll see a reminder of that in the paper. We've had 220 responses to date, which is positive considering obviously we've got substantial consultation work going on CSP and Principal MIU alongside this. We have also held sessions with Swansea Bay team to consider how we can align our strategy work with the work that they are doing, and we are arranging an equivalent session with Powys and Bessie Cadwaladr, who are also progressing similar work. A significant update within the paper is the discussions we've been having with Welsh Government in regard to infrastructure investment, in particular in relation to our ageing estate. So I would describe the discussions to date as constructive and pragmatic, as we try to reach a way forward which responds to the significant risks that we've got, whilst recognising the affordability challenges facing government. I would like to remind the board, just in relation to that whilst we have an agreed strategy, and we obviously approved a programme business case back in 2022, to date there's been no formal endorsement or otherwise from Welsh Government for the approach and direction of travel that we've set out. So on that basis, one of our key priorities over the coming months is to establish what we can agree upon with Welsh Government and what we believe the way forward is from there. To that end, the bullet points set out some of the areas where we in government are aligned in relation to our infrastructure. There are some quite important points there, so that includes that substantial investment will be required. We're recognising that Prince Philip and Bronglais will remain key sites, so we haven't got an unlimited set of options, if you like. We're working within that expectation. Reinforcing the importance of developing community hubs, obviously that's an important part of our strategy, and then the need to redevelop Withybush in any scenario. And then beyond that, the importance of undertaking some work on the condition of our estate and the risks of those on those sites, and we're anticipating the need to produce a hospital site development control plan for our sites to support the development of future work. On that point, I think it is important for Board to be aware that Welsh Government are indicating that due to the capital constraints, the most likely route would involve phased developments as opposed to substantial builds in short periods of time, and therefore that will lead to an extended period and bring some additional challenges in the delivery of the programme. Beyond that, there are two further sections within the paper. One is the section on population health, which highlights the anticipated change in demographics where we can expect for West Wales, and the associated increase in conditions such as diabetes and heart failure, so notably predicted to increase by 22% and 46% respectively over the next decade, and identifies the growth we've seen in inequality between the least deprived and the most deprived over the last decade or so. We're recognising the importance of partnership working within responding to that and supporting a shift towards prevention, community-based care, and obviously the social model for health, which we expect to remain a central part of the strategy once it's refreshed. And then finally, we have a section on digital. The key aspiration within that I would draw out as moving from not just digitising our existing services and our existing models, but to fundamentally reimagining how care is delivered and access for our population, when we're going to need to work with our population in relation to that and the change in expectations. And then a specific reference, of course, in relation to artificial intelligence, which since the strategy was developed in 2018 has now radically transformed as a tool. So we're fully expecting that will be an important part of our strategy going forward. So I will stop at that point, Chair. Thank you.
Great. Thank you, Lee. Very helpful. Colleagues, any thoughts or observations? Rodri.
Yeah, well, you mentioned and you touched on Swansea Bay. How close are we working with Swansea Bay, and are the kind of the discussions, the workings between us, are they fruitful or are they kind of blockers?
Yeah, happy to take an answer. The reference I was making was in relation to how we can develop our strategic thinking together. So we've had a couple of conversations around that, and I think that will be fruitful. And the ambition there is not that we have one strategy for the two of us, because we'll need individual organisational strategies, but we believe that we can develop our strategic thinking in similar ways so that then they become compatible. So then you could have a South West Wales version of the strategy and so on. And equally, similarly with Betsi Cadwaladr and Powys, we could have a Mid Wales and so on view of our strategic thinking. So I think we'll be able to achieve that. Obviously, we're all at slightly different starting points, so sequencing and aligning that takes a bit of thought, but I'm sure we can do that. I think perhaps your question was a bit more general than that, which is about service delivery and so on as well. We meet very frequently. I think in principle terms, we've got very consistent views on how we want to deliver services and design services across South West Wales. The challenge often is more in the practicalities of that. So we've got an unsophisticated LTA model, for example, financial flows to support that. We obviously have limitations in terms of constructing new facilities that might serve regional populations and so on. So it's more the question of how we unlock the changes that we want to see. Governance is another key question for us, how we create governance arrangements that serve a regional population as opposed to individual health boards. So it's more the practical steps, I would say, rather than the principal objections to change.
I think that's important because that co-working is so important in every way, and it's good to know that that dialogue is kind of fresh and it is happening.
Well, I think the joint committee is a really positive space for us having these conversations, and there's enormous goodwill, and trust at that level. But as Lee points out, it's a complex scenario, trying to think about how do we integrate or share or build joint delivery models across that, regardless of the fact that we're all committed towards doing that. It's going to take more time. Thank you, Rodri. I'm going to come to Eleanor, then Maynard, and then Anna.
Diolch Neil, diolch Cadeirydd. Thanks Lee, this paper made me smile, which some of the papers were hard reading and were in difficult circumstances. It's a look to the future, it's refreshing our strategy. It's a complete recognition of we can't do this alone and the importance of partnership working. Some of the things that are working really well for us are those integrated care centres, are when we are working with partners in the community, be those local authorities, third sector, working with Swansea Bay. And this pulled it out for me because I think we need to keep pushing in this direction. To go back to those integrated care centres and the investment in our estate, we need to be working so closely with Welsh Government and grateful for their support because the one in Abereiron, where I was at with the CABSEC, worked really, really well. The ones that are in the pipeline around Cross Hands and the peninsula will make a huge difference to the communities down in those areas. And I know they may take time, and I know the capital will be not a huge lump now, but if we can use these as planning and blocks, they go towards a question I asked earlier about how are we moving from where we are now to the future. So it wasn't so much questions from me, but actually an endorsement of the direction of travel this is taking us. And thank you for the paper.
Thank you, Eleanor. Maynard.
Thank you, Chair. Again, it's more comments than question for me. It's really great to see the section on digital in there. Read it with enthusiasm, as you would expect. And it was great also to see the intention not to leave anybody behind using in the digital inclusion. A couple of flags, there are financial implications around this. That as we invest in digital, we are investing against a backlog of underinvestment in digital across the whole of Wales. It's not just a local problem. And it's been good to see the recent business cases that have come through to the committees showing positive financial benefits coming at the end. So it's that peak we have of getting over the initial investment to deliver cash releasing and service transforming benefits at the end. There's a couple of things from a negative point of view in terms of one of the issues that we have as a patch is connectivity. Anybody who's travelled around our patch has been through those patches where we have no phone signal at all, let alone good enough signal to actually deliver clinical services in the community. I think there's a need for us to work with commercial partners, BT, Virgin, and all the other telecom suppliers to actually try and improve that connectivity in our areas. I know the Regional Digital Inclusion Group has had some presentations on some innovative solutions in that area as well. So it's just an area we need to be careful of when we design our services. And on AI, we also need to be aware that when we embrace AI, we're also having an environmental impact. The amount of energy on a single AI query is probably more than your home PC runs in a whole year.
Yeah.
So it's quite important, because if we're aiming for net zero, then that's a contributing factor. And the final thing is, Lee's already dealt with all my questions on the strategic infrastructure investment. Just wanted to remind the board of the scale of it. That it's over £300 million that we're talking about. It's not a small amount.
No.
And anything we can do in that area, particularly with Welsh Government support, is to be welcomed.
Thank you. Well made, Maynard. Some good points there. I'm going to come to Anna, and then Hugh, you might want to come back on the digital question. Anna.
Thanks, Chair. And Lee, apologies, I think I may have missed the last board seminar, otherwise I might have mentioned one of these things here. It's not a biggie, but just a reflection around the principles. When I read those, I thought, well, some sound like principles and some sound something closer to enablers. And it'll be interesting to see if in the conversations that are going on in the organisation at the moment, whether there's any similar, comment around that. And I think, given they are principles that we will have to hold decisions up to, it is really important that we get, we get them in a fit state to be able to do that task when that moment comes. At the moment, they are sort of in the abstract and rhetorical almost. But there will come a moment when these decisions have to be held up against these things, and they really need to be very crisp indeed, I think. And linked to that, and I think I have shared this reflection before, I wonder where the STEEP principles fit in this. We've stuck with our safe, sustainable, accessible and kind, and I understand why we've done that, and it's familiar language. I think you could equally pitch for it being framed around STEEP. But whichever way we go, the one that isn't in the foreground at least needs to be mapped into the one that we have used. So I think where would we allocate those 6 aspects of STEEP against our own local framework that we've chosen to run with? I think that would help again with transparency and with the sort of crispness around principles versus enablers. I would share one comment that I have been particularly struck by in the public events that I've been attending as part of the CSP process, that while I think we often use transport and travel as synonymous terms, what I'm starting to pick up in listening to stories from other people, and I'm sure colleagues are too, is that travel is something bigger than transport. Mm-hmm. So if the transport is sort of physically people moving, how do I get from town A to town B, or village A to town B, whatever it is? That's in a way a much more containable question, and one that can be facilitated in relatively uncomplicated ways, even if it's challenging to do. What's harder is the broader travel consequence for people who've got responsibilities at home. So I've heard a story, for example, in Aberaeron about if an appointment turns into a day trip, we can't leave the farm for that long. If an appointment turns into a day trip, I can't leave my elderly husband who has dementia for that long. And yet I look out across from my kitchen window and I can see one of our hospitals. It's those sorts of things that I think we need to kind of remember, that this is much bigger than the physical movement of people across our patch. It's also the consequences when people have to leave home for long periods of time. And I've been very struck by that in the patient stories the public stories we've been hearing about in those sessions. My other comment on this paper, which is perhaps closer to a question, is around the Welsh Government position. I mean, if we look at page 7, the first document says we've had no formal response from Welsh Government in relation to our programme business case, but they've confirmed that this document is no longer fit for purpose. I mean, I take that as a formal response, isn't it? I mean, if they're saying it's not fit for purpose, it's dead in the water, isn't it? So do we need much more formality to understand that this is not going anywhere and the context has changed and life has moved on and we have to think in different ways about this? So I would be interested to know what else are we holding out for other than being told this is no longer fit for purpose? And linked to that, I guess, if we are on the receiving end of that message and if we are sort of understanding of the consequence of the reasons for that, is there therefore an assumption that Welsh Government are supportive of the consequence of that, which is that probably in the long run this will cost us more money to pull off, so we can phase the money over a longer period of time. We don't have to have a single moment when we've got a huge amount of capital, but over time it'll make basically a more expensive system for us to run. Is that understood as a consequence in what Welsh Government have said to us about basically Wales can't afford a new hospital?
Very helpful, okay, and insightful as well. Thank you. Did you want to come back on that?
Yeah, I mean, Lee may have a view, but I think it's a fair point about the not being fit for purpose. I think in saying it's not fit for purpose, there's a big difference between the whole content of it, everything behind it is not fit for purpose and completely needs to change, and the fact that the document is now a number of years old, is founded on a strategy that was pre-COVID, and that we've learned a lot since then. You know, digital and AI, for example. So I suppose, yeah, we could take that document is not fit for purpose and is not going to be approved. I think that you're right to say that I think is accepted. The question and your second point about do they accept that it would cost more an alternative versus what was proposed in the document? I think that is the subject of the discussions that we're having with Welsh Government at the moment. Because in those discussions, what we are working on with government is the fact that we have an over 250 million backlog maintenance issue, where there is there's a financial consequence, let alone a clinical one, to trying to maintain or upgrade our current estate, which might cost more money than a new facility. So there is a sort of public value discussion at the heart, of public value consideration at the heart of our discussions with government. And I think where we're what we're finding, I think, is that in our discussions with Welsh Government, I think the fact that we're not entering into those discussions with, well, we've got a plan A and that is the only option, and you either support it or you don't. I think our conversations with government at the moment are about, well, what are the multiplicity of options given our current circumstances that we find ourselves in. And I think as we develop more clarity on that and more agreement with government, we'll need to present that back to board, because there may be options for us then to consider, and that will, I think the timelines of that will naturally fit with the iteration of our strategy.
Great, okay. You might want to come back. Hugh, did you want to come in first on the digital?
I guess directly on digital, but I'll just comment on the issue in terms of capital funding. Naturally, we are all aware that there are significant constraints on capital availability for Welsh Government. And of course, in terms of value, I'm also very conscious that delaying introduces more costs because inflation plays a part here. But come back to the principles of value is economy, efficiency, effectiveness. Economy means that it needs to be delivered within the allocation resources available to us as a system. And if that's not available to us, that is just one of those constraining factors that we have to acknowledge, but work with government on what that means in terms of the longer term. In terms of the digital challenge, oh, sorry, Phil, did you want to come back in on that?
No, I was suggesting the microphone might get a bit closer to you.
Sorry. In terms of our digital challenge, I firstly want to start off by thanking Maynard for the work that Maynard does in that regional space on digital inclusion. I think that makes a huge difference for us as a system and is a standout part of our response to our community. Absolutely have to recognise that we're starting off with a significant digital deficit for the very same reason and challenges that we've got with our capital builds as well. And I'm very conscious in conversations I have with the Chief Executive, as someone who's come up and knows our digital systems very well, some of the constraints that there are in the very baseline delivery of our digital services, let alone in the more developmental areas of artificial intelligence. That's a challenge and conundrum we have to deal with as part of our planning cycle, and that's included within our thinking in terms of the medium-term financial plan we've got. We do need to bring something back, I think, to board at an appropriate time in terms of what we mean by artificial intelligence, because we talk about artificial intelligence and I think we all automatically think of ChatGPT, but actually there is a range of other providers that are available. There's a range across a spectrum from machine learning to pure artificial intelligence in that generative space that I think we need to consider, but we need to make sure we're approaching this with the right guardrails in place. And I'm conscious AI is not going to be the sticking plaster. We need to stick all over our services to make them better. We need to fundamentally change our services to be appropriate in a digitally enabled era.
Thank you. What's really interesting is that I generally think of the digital, the kind of our approach to digital, and certainly your approach, Maynard, chairing the committee, and your approach, Hugh, to be one that's slightly constraining us in a positive way against going to the very end of this, where this logical debate would take us. You know, I'm a big advocate for us thinking the unthinkable in the space of AI, because we are going to be there. Within no time, we are going to be in that space. But I think it's also wise for us to be cautious about that, and to also, as you've quite rightly pointed out, weave a pattern that makes sure that we are integrated and intelligent in our use of any intelligence assisted scheme we might want to use in the future. So I thank you for kind of occasionally holding us back and tempering our enthusiasm inside this space. Yes.
If it's okay, well, just a couple of quick points into what you said. So just on Eleanor's point earlier around shift to community prevention and so on as well, I think within that, that presents us with quite a significant dilemma, really, which is going to be at the heart of our strategic refresh discussions, which is, if you look at the data, it's pretty clear we can't have a strategy that simply is we will treat all the additional ill health that we are expecting, and therefore we're going to have to make quite a significant transition towards a health service as opposed to a health care service, and within that presents quite significant practical challenges, because as you mentioned earlier, Ellen, we're going to have to find the opportunity in the space to move resources away from treating ill health today in order to promote good health for the future, plus make the transition to digital and other things that will make us more efficient and effective. And that is going to be at the heart of the healthcare challenge, I guess, for the NHS more broadly, but certainly for us over the next 10 years. And then the second point I just wanted to throw out is in terms of Anna's question. So, yeah, so what we've done here is because we hadn't had a formal response, we had comments on it, but we hadn't had a formal response as to say it wasn't going to be progressing. we wanted to test that, I suppose, to get as clear a definitive answer as we could, and I think we've got that now. That was our expectation anyway, but because it hadn't been explicitly said, we wanted to get to that position. So now the question becomes, what do we do from there? And obviously the programme business case will need to be superseded by some further work. And within the point about whether it's in a phased way or in a more concentrated period, which obviously would necessitate more capital, I think my expectation is that will come out through the further options we're going to need to test now as a result of what Welsh Government have asked us to do. So rather than just having a relatively narrow set of options which delivers the strategy in the shortest period of time possible, which is what the programme business case was designed to deliver, we now have a broader range of options which will look at also the question of phasing versus big bang, if you like, but also the nature of those solutions as well. And that will therefore present a series of options for government to consider, which we would then obviously be looking to reach a point where they are accepting the capital and revenue implications and service implications of whatever path we choose. Now, obviously that doesn't necessarily mean we'll get more of capital or revenue or anything else, but it is just being cognizant of the true implications of any decisions that are made. So we're not at that stage yet, but what we're trying to do is set out a path that will allow us to work alongside Welsh Government to get clarity on some of those questions and then own the consequences of those decisions.
I mean, for me, the success of this will be on how compelling we are in our approach to what we think the future delivery model is going to be in West Wales and how we address health needs. I think, and every business case I've ever read has often been premised on just providing that compelling argument for why this is absolutely the direction of travel. And I think we need to continue to progress that. And I think we're well on the way to doing that. So I think this is really taking us in that direction. The other issue we need to do as well is that having a conversation with Welsh Government that says, give us 1.5 billion pounds, because we want to get on and do this. We absolutely know at heart that is not feasible at the current time. Would it be that Welsh Government had money in their back pocket to give us that money? Then we would say, great, but we know that's not the case. So there is something about how do we enhance and enrich our perspective on what we want to deliver in West Wales that's cognizant of the art of the possible by government at the current time in terms of its financial restrictions as well. So it is a complex kind of formula for working out what we need in the long term. I would echo Eleanor's point that largely our approach needs to be very much, and you said it, Lee, it's about how do we create health inside our communities as opposed to just become a healthcare service. How do we think much more about that? And I think we've already started to make some inroads inside that space. I think our integrated approach to integrated healthcare inside our communities is at the heart of developing that model, and we're proving it's a successful model. We need to do more in that space in the future. So, very good paper. I'd echo that. I think it's well crafted, and as Eleanor says, if a paper provokes us to think broader and more deeply and wider on these issues, then the paper's achieved that outcome, and we look forward to the next iteration of this in the future. Thank you very much. Great. Okay. So I'm going to slightly rearrange the agenda now. Partly because Dr. Karen Brown has joined us at the back, and I'm conscious we'll be boring her to death if we continue to talk about all kinds of things that she might not want to hear. So what I'd quite like to do is to bring the item forward where we are looking at the unplanned emergency care proposition, or how we move forward inside that space, and then Jill, we will pick up the primary care paper afterwards, because I think there's a connection between these two things. And Karen, you might want to stay for the purpose of that paper, just to be part of that conversation as well. So if everybody's comfortable with that, we'll move to item 16 at this point. Andrew.
Thank you. First thing I was going to say is apologies around the lateness of the slides that were shared. I'm not planning to slavishly talk through those slides or even show them. I think they set out a bit of a framework for some of the issues we're grappling with, but I think there's a few points I wanted to make in introducing the item. I was going to give Karen an opportunity then to share some of the clinical vision around where we want to get to and some of the first steps to that, and then open it out for a bit of a conversation and discussion, because I'm very conscious that we spent some time on this in our board seminar about a month ago as well. So from a board perspective, a number of the issues would be kind of familiar. So I think I wanted to start with a sort of a kind of acceptance or reality check around the baseline position and where we are. And I think, as we heard earlier on in the performance item, our urgent emergency care performance and service is, from my perspective, delivering an unacceptable standard at the moment. We are giving people a service that's requiring them to wait too long at all stages of that pathway, and it's a very difficult service for our staff to work in, who I think at times don't feel as supported as they should do. And so there's a huge amount of, I would say, opportunity for us to make this much better. What we do want to do is we do want to make sure through the work we're going to talk about that we do have a service where there aren't those delays in accessing, and we've got to redesign the way we deliver that to achieve that. We do want to make sure we've got a better patient experience as a result of this, and we want to make sure our staff feel supported and their experience of working in the system is one that it's a system they're proud to work in, but also they can see how their ideas, their views and their contributions are supporting the local population, because it's a very difficult environment at the moment in which to practice clinically, and whenever we go round, that's something you hear quite strongly. I think in thinking about this issue, we've effectively got three timelines. I think, Chair, you would call them horizons, but there's sort of three viewpoints really in terms of this work. We've got a really immediate pressing pressure over the next 60 days around ambulance handover performance. There will be a change in the way ambulance handover is managed from an ambulance service perspective on the 1st of October, and a way of making sure and enforcing a 45-minute maximum handover time. We need to remember that the actual target is 15 minutes, so 45 minutes is actually quite generous. It's 3 times what the national target would be. But at the moment, our performance, as you've seen from the performance report, is a long way from 45 minutes. Our average on any given day can be well over an hour, 2 hours, depending on how busy it is. So that in itself is a real challenge. And so we're going to have to make, over the next 60 days, some really urgent changes to decompress our emergency departments, to make sure we've got the space to receive those patients that are being brought to us by the ambulance service, and enable the ambulance service to go and respond to the patients in need in our community. We'll need to learn from others. We've talked a bit around the great work they've done in Swansea. We're aware of significant progress they've made over recent weeks in Cwmtaf as well, Cwmtaf and Organic Health Board, and so we will be going out and making sure we can take all the wisdom from their experience and what they've done to support us here. What that is likely to mean, though, is there'll be what I would call sticking plasters put in place over the next 60 days to try and manage that position, but that may not be sustainable long term, but will get us through the next 3 or 4 months, and we can possibly talk about that a bit more when we get into the discussion. The second timeline then is around winter, and how do we start to strategically reshape the system to make any improvements we do make over the next few months, which we will have to make, more sustainable as we get into what we know is a very difficult time of year, and how in doing that we start to put in place the foundations of the direction of travel we want to go in, because I think we've got a very ambitious plan and vision for the delivery of our service in this space, but we need to start making the steps to get there. And I know Karen will want to talk about that a bit more in terms of how we would prioritise our first couple of areas in taking us in that direction. And then the third one is probably more of a medium-term issue, which is how do we, at a systemic level, redesign the system with our partners to make sure that we're able to, across the whole spectrum of care, from prevention all the way through to ongoing care need post-discharge, we've got a system that truly meets the needs of the population, and which we know is ever-changing for us. And with some of our demographic projections, some of that is going to become even more challenging for us in the coming years. I think in doing that, and to deliver that, the scale of transformation and the shift in the delivery model to which we want, we know operationally is going to be really challenging. There's a level of risk in how we're going to have to approach this that is going to feel uncomfortable for me and my team in terms of doing this, but I would suggest as a board it's going to feel uncomfortable to us in terms of the risk we may have to take in some of our decision making to enable us to progress our vision. The fact that this is a really complex system and the systemic nature of the change we want to make means that I'm grappling with how I'm going to have to lead that in a different way, and I'm going to have to take a different approach to leading that, not try to oversimplify it all the time, and accept to a degree that sometimes the input and the output I describe may start off as in one space and look very different by the time we get to the final iteration or the final model that's in place. What I do know is the evidence behind what we're talking about is really strong in terms, we talked earlier on around the value proposition of the service we're delivering, and the value proposition in the evidence behind everything we want to do and put together is really very, very strong. So I'm very confident when we get there will be a significant benefit. And it's interesting because in some ways what we're talking about here ties together some of the conversation earlier we had around the financial challenge and the roadmap work that Hugh alluded to, that we've started a conversation on as from an executive perspective, ties into how do we make sustainable improvements to our performance, but also it becomes a fundamental part of our strategic refresh and some of that conversation we need to have with our population around how we want them to access services. We will need them to access services differently, but on the basis that what they're going to get is a far more timely and accessible emergency response than they're receiving now. So on that, I was going to hand over to Karen, if that's okay, after just saying those few things, to sort of give us a bit of a flavour of, I think, because we've not done this in public before, a bit around what the vision is, but also what our early thinking is now on how we start to develop that in time for winter to make winter a better scenario for everyone, and then we'll come back a bit on how we plan to bring that back through board over the next couple of months.
Great. Okay. Thank you. Karen, you're very welcome. First board meeting.
Thank you, Andrew. Thank you, Chair. You've got a red light on, Karen.
Can you hear me now? Sorry, it was on all the time then, actually.
Yeah.
So thank you, Chair. Thank you, Andrew. It's a pleasure to be here today. So I think building on what Andrew said and what you've discussed, what we want is an enabling service that has our citizens at the heart, and what matters to them is at the heart of what we enable our staff to do. So over the last couple of years, we've really co-created a vision, a model, with key stakeholders, every voice at the table, looking to that emerging future. So recognising health and social care is complex, it's an adaptive system. We have done things a bit differently. So there's been a bottom-up co-creation of a model which has been clinically led, very much person-centred, so leading from the front of what matters to our citizens in the community, whether that's villages, towns, whichever county that is in West Wales. So we shared the integrated urgent emergency care model with board at a seminar a couple of weeks ago, as Andrew mentioned, and this very much is looking to move from a reactive system to one that is proactive and preventative, where we're enabling people to live good lives well in their communities, to enable people to be self-managing, to be activated and to be experts who have control of wellness really more than health, so that we build on what is strong for them, not focus on what is wrong, as we often do. So how can we do that as a relational public service? We want to walk alongside our citizens to help them in times of crisis, so that we can have a system which is accessible to all to manage when and where they need it, so that we move from the sort of notion of getting it right first time, but getting it right for everybody. So within this model, we've thought very innovatively. It's been many frames and lenses at the table with an extensive engagement and socialisation process, essentially, which builds on prioritising our connected communities and working with third sector partners and charities so that people are enabled to live well. However, when they do have a crisis, that they can access high quality care closer to home, and that can be done in a way that is relevant for each of those individuals. And then when they are being cared for within our system, how do we enable staff to care for those individuals in a way that their journey flows through the system, they tell their story once, and that we reduce that inherent duplication waste within the system. So we want to create a system that's enabling to all. We've had a look at the data for our own health board and have found that actually 50% of citizens who visit us in our emergency departments could be better supported elsewhere. About 28% of those could attend an integrated care centre, such as Eleanor and others have mentioned, our same-day emergency care. And about 13% of those who may have more complex needs can be supported by our intermediate care multidisciplinary team. And how do we start to stream those crisis needs in an efficient way so that it is of value to the citizen, the service and the system? So we want to focus on what matters for citizens. We want staff to work to the top of their licence. We want to facilitate value for all. And as I mentioned, build on what is strong for our current and future generations. So in terms of that left shift, in terms of promoting well-being and prevention in terms of the social model for health and well-being and our proactive crisis response, we want to be able to walk with citizens as they undertake the healthcare journey. So this, in 4 main areas, constitutes access to care when and where they need it, walking with people in a journey that makes it efficient and that removes the weights, expertise at the front in terms of senior decision making, enabling processes and structures to do that, and then taking care into the community. So a move away from traditional structures where care is focused in hospitals, but actually, as our public have been saying to us for many years really, to deliver care closer to home. So that will involve taking hospital diagnostics into the community, taking treatments into the community, supporting individuals to have healthy quality of life in the community. And all of this absolutely is underpinned by digital transformation and modernisation of not just our services, but the education and training that underpins that. So in terms of that being perhaps the third horizon and our ideal where we want to get to, we do need to prioritise how we can shift. It's very easy to say we need to shift left, as Andrew's alluded to. Operationally, that's very challenging. So in terms of access, perhaps we need to think about redistribution of our expertise and have those senior decision makers at the front, look at points of access to our system and how we streamline that. But particularly looking at our capacity, which is a huge challenge at the moment. How do we spread those services equitably across the 7 days? How do we enable people to access that urgent emergency care at the weekends in a timely way that means they're not waiting many hours in A&E, either on an ambulance or in the waiting room? And how do we steward the crisis response to an individual within the system, optimising and efficiently utilising our multidisciplinary teams so that we can make every contact count for our citizens and our staff. And inherently within that, there's also the challenges of flow. So how do we make complex decisions to stream people within healthcare options within our system? And how do we enable that continuous flow through our systems, not just health, but social care and back into the community? So in terms of the next sort of 3 to 6 months, there will be some decisions that we need to make in terms of enabling some of those as short-term solutions. But actually, in terms of building that brighter future, we want to come back in September to expand around a 7-day business case model for our same-day emergency care services and our clinical streaming, as this will effectively help support 40% of that 50% that could be better managed elsewhere within our system. Thank you.
Thank you, Karen. The thing I would take from what Karen said, well, lots of things. The thing that feels to me really important, and I think you echoed, Andrew, is just the sheer complexity of this system, this enormous system, which doesn't exist in one place. It runs through our communities, it runs through our services, it's embedded in our primary care services, it's located within our secondary care services. Just the enormity of this enterprise, we can't underestimate. And I have a real sense that we have to operate without knowing the answer to all the questions, which I think is exactly what you're alluding to, Andrew. As a board, we want 100% cast iron guaranteed assurance that we can answer all the questions all the time. And I think this is asking us to be brave and a bit courageous in this space, to be able to trust a process that will deliver the outcomes we want. But as you quite rightly point out, we are not quite sure exactly what those might look like further down the line. So on the one hand, we're being asked to be really brave inside this space. On the other hand, we have a governance role, which is about ensuring that we use our resources well and that we can justify our utilisation and our direction of those resources to deliver the best possible healthcare. We talked this morning about a value-based approach to the way in which we make decisions or how we deliver our services, and I think that value-based approach lies at the heart of what you're suggesting. If there's a genome inside this we should be aware of, it's how do we empower our clinicians and the people who are working in that coal-face situation to intrinsically make the best possible decision they can in the moment they want to make it, instead of relying upon a whole kind of system of controls that are often not helpful. But that's a big cultural shift on the way in which we conventionally deliver our services, and it will require us to be quite courageous and brave inside this space if we wish to endorse this model. Observations or questions? Sarah, and then Chantal.
Thank you, Chair. So first of all, to say, Karen, I'm hugely supportive of the work your team are doing. I think it's absolutely what we need to be doing. I'm really pleased that the way you've talked about it today has moved on from when you presented at board seminar, which I felt was hugely evidence and academically based. What I loved what I heard today was it was patient-centric, and that makes it much more real for me, so I really appreciated that. Thank you. I think, to echo what I talked about at board seminar a little bit, I think we shouldn't underplay the role that the enabling work streams are going to have to play out. I have a question around whether we have sufficient transformational resources to actually embed the change in a long-term way, and I know you and I have talked about that offline. I have another question around how is this shift left, this dramatic shift left, going to be articulated in a link between what your strategy is doing and the primary care strategy? How is that going to play out? Question mark. And then I just have a slight challenge on one of the points in the slides where, and I'm going to quote from them briefly, we have a high confidence in recruitment due to current local and national interest and reputation. I'm not sure that that aligns with everything I'm hearing about our recruitment challenges more broadly across most services, so that's just a little bit of a challenge, but generally, absolutely love what you're doing. Well done.
Very good. Chantal?
Thank you, Chair.
Karen, I'll take a couple of comments and then I'll come back to you for answer.
Yes, I totally agree with Sarah, and I think this is the right direction of travel, and I think well done for bringing it to that particular point. I just wondered whether we've given consideration to the barriers to implementing this. What are those issues that may crop up that will actually derail the whole of the project? and that will stop us from from implementing this. I mean, that's one of the things that I didn't see within the papers, what those barriers might be.
That's a very good point, and I suspect with more time and that discipline around it, we need, because those barriers are our risks. They're fundamentally our risks, and we need to risk profile this work. Even if we can't control those risks, we need to know that they're there. Absolutely. Eleanor?
Thank you, Karen. Thank you very much, Karen. I've been down to see you in the unit a few times, and the atmosphere and the working atmosphere amongst the team is really good there. I sat in on your multidisciplinary team, people coming in off their days off to work there. What I'm really interested about is how we continue this, how we replicate some of this. Yeah, we have to manage enormous uncertainty. There is something about getting to maybe that we just don't like as people, but linked with the integrated healthcare centres, linked as I know you do with Porthracelli and the social care, it is getting to that patient-centric part of it, and at the same time taking people out of A&E and probably, but not yet proven, saving us money. So those are my comments on it, Chair. Diolch.
Great. Karen, did you want to come back on?
Yes, thank you. Thank you for the kind comments. So with regards to the recruitment and retention, there's a huge amount of interest in an alternative model that we've been creating. So we've got quite a few advanced clinical practitioners who are waiting, some on zero contract hours, to come and work with us. Some within Wales, some nationally, so southwest England. So lots of people have spontaneously contacted and said, oh, we've heard what you're doing, we're really interested to come and work. So that's very different culturally to unfilled posts. So there's something about the excitement, the enthusiasm, the change, the transformation there being radical. So that's where that line came from in that to Sarah. In terms of the barriers, I think, every sort of crisis is an opportunity. This very much was intrinsically built from passionate colleagues on the ground who just couldn't continue working in the way that they have been. We've seen fantastic integration by people coming together, bringing their potential in terms of what they can bring, their teams, that systemic working, that the outcomes then in terms of efficiencies, ability and productivity is just compounded. So creating an infrastructure and a system that is enabling to all who are working within it is partly how we will spread this. A lot has been done by individuals in a sort of strengths-based way across the system, but actually if we can then endorse this, if we can create kind of conduits within the system, within our infrastructure, that we promote individuals' agency, we trust them, we empower them, then that is how we will effectively network this, because it isn't an individual siloed approach to things. It touches every path of our health and social care system. So everybody is a part of it. Everybody can contribute, everybody is responsible really, and in that way we massively will augment our outputs and outcomes and our experience for our staff and patients. So I think, some of the biggest barriers are, not having that 100% answer. This is pioneering edge, this is an emerging future. So it's trust going into something that actually our biggest resource is our staff, and all of those staff, have come into a vocational service that they want to do the best for their, friends, family, their community. So it is, as Lee said before, being dynamic in an approach to doing something. So yeah.
I mean, just to pick up on the point I think both you and Sarah have made, we have talked about needing to swing to the left, about needing to kind of absolutely change the fulcrum that we're operating with, and the centre of gravity needs to move much more towards that kind of prevention, primary care, community service kind of approach. And I think this is taking us in that direction. Strangely enough, but it feels to me as if it's been generated from within the secondary care bit of our business, that we're delivering this kind of swing to the left, which I think is deeply original and not as I would have predicted it would have been. But we've always acknowledged the fact that the reason why we've never moved to the left isn't because we aren't committed to doing that. It's because the complexity of that step and the enormity of having to make those changes is such that often, you know, our energy is dissipated and our intellect and our resource is dissipated at the point where we've begun to see what we could do inside this space. And it feels to me this is offering us an opportunity to do that. But there are enormous risks to this. There's an enormous financial investment in this change. Now, in the order of things, it is not a big investment. Okay, it's a relatively small investment for a very large, impactful outcome. Presuming we will get to that, the outcome. Within the current financial climate, it's a big investment for us to make at this particular time. So my point is that we do need to be brave inside this space and be able to invest in people like Karen and others, that we can deliver this. It is something that we want to do and create that shift in the way in which we're working. Phil.
Yeah, look, it's great to have Karen, to have you here presenting it as well. So at the heart of any transformation of this kind, there's always clinical leadership when you look anywhere in any organisation. So I think that does give us a chance, actually. You know, because without that, we would struggle. And I know that Karen has been engaging across the system, including primary care. So whilst it might have been sort of birthed in the hospital bit of the system, I know the tendrils of this work, in engagement terms, spread out across our system. So that, I think, it gives us some reassurance from that point of view in terms of that approach. I suppose just going back to the three horizons, we and our three horizons here aren't the traditional three horizons of 1 year, sort of 3 years future. Our three horizons we're describing are 60 days, then probably till the end of the year, and then the future. And my point would be that everybody engaged in this needs to be engaged in every single horizon. I don't think we can have some work like Karen working on the future and then someone else working on the next 60 days. We need, you know, the leadership needs to be on all of it. And the other thing we can't do is, in my view, is just work on the 60 days over the next 60 days and then get to the next horizon. And then by the time we do that one, get to the third horizon. People make that mistake quite routinely. So I would say we need to be engaged in all of it. Now that's difficult because that's a lot of work and that sounds a bit messy. But that really is the challenge that faces us. And 60 days, it's just over 60 days really until the 1st of October. It was yesterday, I think, when I calculated it. And that, you know, there's a significant risk because the target will be delivered, you know, the ambulance will hand over patients, and we need to make sure we've got the safe measures in for our staff and our public in that scenario. Now, we're really good as an NHS at engaging with the significant challenge. We've seen it in COVID. We're good at action-based work, but this is going to be difficult for us. I do need assurance that we're you all need assurance. I need assurance that we're all on all three horizons. We are. I think, Karen, I can see this turning from the sort of theory and academic into the practical, and I think we need probably more and more of that to give us assurance. I would suggest that to give us. To give all of us, start to give us confidence, our staff, our public, us as a board, we really need to make that progress in the next 60 days. Because in terms of reputation, I mean, Swansea is all over the news at the moment. Cumtaf will be, is it for the progress they've made. We aren't, for good reason in that regard. And so our reputation, that, you know, at the moment, I would say people will look at that and perhaps choose might choose Swansea, although hopefully we can turn that around. Hopefully people listening to this will see our ambition. I think they like the culture and the way we work. In terms of next steps, which I know you want me to get to, I think I've talked to our clinical operational team, clinical operational execs. I think we need much closer oversight from our executive colleagues. So I know Andrew's already signalled that for himself personally, but I know I spoke to Mark, James, Sharon. I think those three groups that we have, the flow, access and environment, we need our clinical execs much more close to those. We need to discuss the implications of that, but I think we need that level of scrutiny given the urgency of all of this, that we have the practical clinical governance in place. In terms of the finance, this gives us quite a challenge, because we've just had a discussion earlier about the Cabinet Secretary's very clear expectations that we find a route back to 24 million. And Appendix 2 of the finance paper has got some really difficult challenges for us there. So we are at the same time as considering that Appendix 2, the risk assessments of that, the Finance and Performance Committee. We will need to consider the next version of this, albeit understanding that it's very difficult. It's not quite so binary that we do this and this happens, but we do need some a next step of that will help us get behind it.
Great. There's two other people who want to speak. Usually I give you the last
words
so you can echo the most. But actually I'm going to come to Moape, and then I'm going to come to Hugh. Moape.
Thank you very much, Chair. My question is to Karen. Thank you very much for that presentation. Very informative, and I like the direction of travel. I just wanted to ask if you could maybe talk more about the community, patients to be exact, because they are at the center of this transformational change, and we do know where there's change, there may be some level of resistance due to various reasons. So my question really is, what consideration have you made around the community involvement and the role that they have to play in participation and ownership of this transformational change that you've told us today? Thank you.
Thank you for that question, very insightful. So the community has been the inspiration for this, really. This is a repositioning of us as a relational public service to providing what the community have asked for. So many consultations over many years. Every day patients say, please can you provide this at home? How do you enable me to make decisions for myself? How do I have more control over my own health and well-being? There's a big part to do with obviously education and support in that aspect, and Mandy was talking through some of the listening and learning work earlier. So learning is a key thread to this. We're learning how we adapt to respond to the community. So at the board seminar, I shared an image around a layer, and actually this bit of the work is building on connected communities where we are helpful outsiders in that space. And it comes back to the so what question. We're changing as a response to being asked. To reassure you as well, we have weekly meetings where we have patients coming, unpaid carers, working very closely with CLICE, PAVS, CAVO, CAV, lots of different charities around what matters to citizens, but also importantly our staff. And we want staff to feel they're doing value work, where they're engaged and they are productive. So this is an unusual way of change evolving, I suppose, because it has been bottom up, but absolutely that's been intrinsically motivated by all of the staff wanting to respond to how they can best support citizens in the community. So it's a much bigger piece when we then start talking about unmet need or not need. But this really is a focus of how do we respond as a health and social care system to change that balance, I suppose. So absolutely, it's at the heart of the aspiration.
Okay, great. Michael and Hugh, might be the same. Go ahead, Michael, and then we'll...
Well, thank you, Chair. It was just a kind of the mechanics of. I'm fully, very excited by the proposal, but we got, as you said, Chair, there's got to be a governance of it. So we want to work at pace. So what is the kind of? I was looking at Joe at this. What's the kind of framework going forward? Because if we looked at it in the F&P committee, which is a month away, but of course there's a big, as you said, there's the risk, there's the quality health, the quality safety issue to it as well. So, but we don't want to make work for Karen and her team by attending dozens of committees. So I just wonder, maybe not an answer this second, but I think that's an issue we need to think about, how we streamline, but have a thorough process. Maybe even the good news is that Anna is vice chair of the finance, and so we got a kind of overlap. But that's something we need to think about, because we don't want to kind of lose pace and make extra work when we want to kind of crack on with this.
Yeah, good point. Well made. You.
Yeah, Chair. Thank you. I think Phil has, to a certain extent, said what I was going to say. I just want to reflect the fact that there is some dissonance here between the conversation we had around saving and a conversation that is about investing in a service. But I think what we're effectively talking about here is shifting resources as the shift in patient care is moved into the community. So it's more a shift in resources. What that does for us, though, at this point in time, is increases our financial risk in overall terms for this year while things bed down. But I do need to see, and we'll work on this in due course, what we're going to shift from. So what are we going to end up disinvesting from in order to make the shift of resource into more proactive care? Now, that's something that we'll be working on between now and the next conversation we have at board.
Great, okay. Michael's well-made point, which is just the governance of this. In a way, we want to let this go, because we want to liberate you to start to get early traction and make these changes. On the other hand, you're absolutely right. We need to make sure that there's a scrutiny around it, and we are assured at the same time. We'll need to talk about that, Joe, in terms of how we can make that happen, so that we don't, the rhythm is compatible between you wanting to press ahead, but also needing to have that scrutiny at the same time.
Just to answer a couple of questions, if that's okay. So, Phil, in terms of the horizons, if we committed to the sort of 3 to 12 months of introducing this 7-day same-day emergency care and clinical streaming hub, that is us investing and building in something that we then layer and grow in terms of introducing the whole model. That's the key change to making it accessible and therefore safe and better experience. In the short term, so the 60 days, we can overlay that with some changes in terms of process, just as a short-term measure that we can't sustainably continue. So things like continuous flow modelling, when you have your next patient and you have that onus of the journey throughout the system, having that complex streaming at the front door. So we change our process and put our experts, senior decision makers at the front. We can do that for a short period of time just to buy us some headspace so that we can embed those mid-term bits so that we don't have to double run and we can have capacity, because that's going to be a key challenge with these changes coming in October with the 45-minute handover. So that can build us some headspace in the next 60 days. But the priority commitment, I suppose, is to that middle piece where we do commit to opening the services 7 days. That will have some resource shift and recruitment in that, but that will enable us to invest in what we need to, but buy that capacity to do it in the shorter term, and then we continue growing it into the future.
Okay. Yeah.
I mean, I actually Sorry. Actually, Karen, I mean, I find that's really helpful and reassuring. You're thinking across those timelines, actually. And I realise some of it that we'll have to make some rapid decisions, and some of it will not be sustainable in the long term, that we have to do in the 60 days. I guess, and people might be willing to go with that if they know that we're going to adapt the system in a much more virtuous way down the line. I suppose then few things. We may have to make some decisions in the next 30 to 60 days, which will find all our governance processes quite difficult to align to that. So we'll need to manage that with Joe and Andrew, I think. Yeah. In terms of the sort of longer term model and the dissonance between the financial paper and the idea of allocating more resource, I suppose one thing we need to think about is where would we prioritise the next bit of it, because you know there's all of it and then there's part of it, and where's the most important bit to allocate first. So I'd probably encourage the team just to think about that as well as we make progress. So
just to close this item, I think what we're broadly saying is we're supportive of this direction of travel. At this stage, we are endorsing of what you're trying to achieve. If there are caveats, it's making sure that there's a governance rhythm to this process so that we can ensure there's appropriate scrutiny without holding you up in terms of moving that work forward. And secondly, that this will require investment, but we will need to demonstrate at some point that balance is off, or that the benefit of this can be translated back into other services that we might need that we could disinvest in or think about differently. So we'll need that as part of that ongoing process. But broadly, I think we're supportive of it, and well done. Very good step forward. Thank you. Great. Okay. I'm conscious it's 1 o'clock and people are probably hungry. But before we break for lunch, I'm quite keen that we try and cover off the primary care and strategic plan, partly because it links into this item and I don't want us to forget after we've had lunch. So if we could just cover off this item first, I think that would be a really helpful thing before we move on.
Thank you, Chair.
Sure.
And actually, the introduction from Karen's presentation and Andrew's is a really helpful foundation, actually, to what I want to introduce. And as you have said, it is absolutely linked. And although there was, I think Sarah raised the issue around separate strategies, there's actually only one strategy, the Healthy Mid and West Wales strategy. And these are strategic plans which are very much part of that overall process, as is the CSP. So I think that's really important. The other thing I think which Karen reflected on around the principles of why this model is being proposed in terms of changing SDEC and looking at those parts of the system. Karen quoted really very much principles that are fundamental to the primary care model for Wales. And so I think it very much fits together from that perspective as well. So I do want to emphasise the importance of the primary care and strategic plan as very much part of that integrated system. But having said that, I think it's really important that we also recognise what primary care delivers in its own right. And 90% of the daily activity which our patients experience is delivered in primary care. And that therefore means, and this was set out by the King's Fund, that if the primary care model is not right, it fundamentally weakens the whole system. So I think part of what we want to do together is to ensure that we've got that right. And that's building on the Starfield principles which are set out in our appendix, which looks at the role of primary care really in terms of that first contact, coordination, comprehensiveness and continuity, because we need to develop those services within our community so that that part of our acute system works well. But there's an interface as well, and part of the conversation we're having together is what does that urgent primary care component look like? So all of those people who need to be seen urgently on the day, where are they best seen, and how do we develop the system so that we have a pathway for individuals, as well as then a system that looks at those who require more complex and comprehensive oversight of their particular needs and concerns. What I also wanted to set out in the paper is that this system is dynamic. So we're not sitting waiting to design something in 2 years, but the system's changing around us. And I think I wanted to confirm the enormous changes actually that we've seen in primary care over the last few years, and we still are seeing. But I think particularly the most recent change in our eye care services, for example, the biggest change in eye care contract reform around optometry services has been made in that last year. So now actually seeing a reduction in the pressure in our secondary care services because we can do more in primary care. So it's a very dynamic system. What we've been doing over the last few months, and it is set out in the paper, is now engaging with our workforce to begin to test some of the principles that we've picked out and been discussing through earlier board seminars. And that will come together then into a larger part of discussion in October. And I would be expecting that we're having a conversation there with our whole system around the model so that it integrates the sort of conversation we've been having now around the urgent emergency care system and the model we need for our primary care system going forward. And then I think finally I wanted to set out some of the national direction that's going to be enabling this, I think, to happen, and is very much part of conversations that are going on over the next fortnight. I know that there's going to be a conversation with chief execs as well at a national level in the next week. So we're going to be seeing some new documents that will come out. They're not published yet, but I understand some of the nature of what we're going to be seeing. We're going to be seeing a refreshed narrative for the primary care model for Wales, which will strengthen. It's not going to broadly differ, but it will strengthen particularly the principles around empowering our citizens and enabling our citizens to live well in the community and how we look at that shift left. We're also going to be seeing a document that's called Accelerating the Opportunities. That's the name it's got now, it might change, which is very much setting out some of the things that we could do now in terms of shifting further pathways out into primary care. Community diagnostics, certain pathways, and describing what those would need as part of that transformation. And then we're also going to see a third document, there may be others, but I know of 3, which is going to be about the development of something called a collaborative directed supplementary service. And that's going to be building on the opportunities that we've got with clusters to be able to more formally engage as I won't call them organisations, but federations or community interest companies to do things that they can't do now, both in terms of commissioners and providers of services. So they can't employ people now, for example. They'll be able to do that. There'll still have to be a host lead. But it very much builds around our systems that we have across our area to be able to look at how we develop systems and services at that local level based on population need to respond to the challenges that we've heard within the service today. So I suppose I want to finish with saying that there are all of these things working through, and our strategic plan will be aligning then with the opportunity to engage with the public, as Lee has talked about later or early next year. So I hope that update's helpful.
Thank you. Colleagues, questions or thoughts? Sarah.
Thank you, Chair. I'm just trying to think about how to frame this. Okay. When I read the paper, what I took from that is we have spent 2 years having conversations and talking. 2 years. That seems to me an inordinately long period of time to be discussing what we think needs to happen in primary care. And when I read the paper, what I see is more conversations that are going to be coming. We have huge challenges right here, right now. And a lot of what I was reading was interesting, models in Hawaii, so on and so forth. Again, I come back to my so what. What are we going to do? I understand that there is I think there's a vision. I'm not entirely sure that I could articulate what that is. I don't understand what our strategic goals are actually going to look like, how we are going to do this. And I'm really just struggling to understand how we can be 2 years into thinking about this and still not have a really clearly articulated strategic plan. I'm sorry if that sounds really negative, but it just feels to me like we are wading through treacle with this stuff And we will never get to a point where we're moving at a sufficient pace to align appropriately with some of the UEC work, which is on this charged mission to get stuff done now. I don't have confidence that we are going to come out of this with a clearly articulated, full strategic plan in the timelines that we're talking about, would be my comment.
Okay, there's a challenge. I think what I would say is, you're relatively new to the board, which is probably an asset in a sense, because we've kind of worked through this over the last year or two, and perhaps become a little bit inured to, to the speed of it, because the paper has merit. It's introducing us to ideas and different ways of seeing the world, and I think you're right, Jill. It is dynamic. We're in a dynamic situation. So what we thought about primary care last year is different from what we're thinking about primary care this year. So there are challenges around that, but I think it's a good challenge. I think it's well made.
Happy to respond. I think I really welcome the challenge, actually, but I will say the timescale was set by the board and actually extended to make sure we align with the Healthy Mid and West Wales. The easiest thing to do, and if you look at primary care plans on general websites belonging to other organisations, they set out a lot of aspirations. They don't do the how. They talk about the what, not the how. And I think what we've been trying to do is to really work with our contractors, our public, in terms of trying to design that how as well. Appreciate the timescales are elongated. It is complex because, we're talking about an enormous number of services here, but also we're bound to a degree, it's not an excuse, by the contractual processes that happen at a national level. And part of the conversation I know I've had in a board seminar previously was that some of the things that we've been talking about are potentially quite radical. I'm not going to say this is agreed, but we were having a conversation, for example, about would we move urgent on the day care services away from general practice to focus on complex and move that into, I don't know, same-day walk-in centre, for example. Those sorts of ideas are pretty radical. Similarly, would we look at looking at going forward a maximum and minimum list size? Because we were talking before around the decision that board often faces with a contract termination. So it might mean in certain circumstances that if it's a small practice, you always end up with a potential dispersal so that you build larger practices going forward. That's pretty radical. And part of the challenges that we've got are not overstepping some of the national conversations, because we could by default have an impact on contractual conversations around some. That sounds like an excuse. It's not an excuse. The other important thing is that if we did have a minimum list size that we talked about in terms of 5,000 going forward, that would be our tolerance level as a board. There are a whole series of practices around North Ceredigion that would be saying, well, what's going to happen to us? Now, it would be about then working in that more federated model. So it's the way in which we work together. So I think there is an acceptance that we need to engage with colleagues. I thought we had a vision, but we'll continue to focus on that, and it's very much part of this integrated approach. So we'll go away certainly and reflect on the conversation here today, Sarah, and think about how we can strengthen that going forward.
Ewan.
Diolch, Cadeirydd. Thank you, Jill, for taking us through that and appreciating in terms of Sarah's comments in terms of time. It is one of those things when you read a paper and you do see a frustration in terms of time taken. But I would say in terms of from a third sector point of view, I would like to extend my thanks to Jill and her colleagues in terms of the engagement, looking at what's happening within communities at the moment and looking to be part of a menu of solutions in terms of what we're looking at. And I think we should remember it's not just primary care we're looking at here, it's also a communities plan as well. And I think the challenge we have in communities looking at that preventative model is, as we've picked up in terms of what Karen was talking about in terms of empowering wellness in communities. So when they come through the front door, has there been that interaction which kind of enables them to kind of remain in their communities? And I know I've spoken to Jill outside of today on numerous occasions about the opportunities which exist within community-led solutions, and I know that's the move in terms of what Lee's articulated earlier today in terms of the Mid and West Wales strategy, in terms of, this shift left. And I think, apologies, I know I sound as if I'm repeating what I always say at board, but the examples we have within our communities are part of the solution. But the challenge, as we've seen through this particular programme, which Jill and her team are working on, is it's not an easy kind of fit because of the complexities of short-term funding, short-term contracts within communities and third sector organisations. You don't have that long-term continuity of expertise and staff by which to then bring it in to be part of the menu of solutions. And just to give you the actual examples of what's happening, and I have to declare an interest because obviously it's one of the projects that I'm involved in, but the Catalyst for Care programme, which works with Hywel Dda in certain elements, not the whole organisation, but is embedded within our social care directorates across the 3 local authorities, is currently supporting 800 people to stay out of our hospitals, essentially, through prevention. And we saw within the report earlier, which Andrew kind of shared with Karen, it costs £443 per admission into our hospitals. If you multiply that by £800, that's £354,000 we're saving for one admission by all these groups, should these innovative community projects not exist. So at the moment, whilst we're supporting 800 people in our community in terms of prevention, well-being and signposting to the right providers and working with primary care and other colleagues, we're also supporting 2,700 hours per week of care, which the local authorities and the health board could not provide currently. So I think the prevention that we see within our communities, the innovation we see within our communities is part of the menu of solutions. It's not the total answer, but I think in terms of looking at a primary care and community strategic plan, I'm really grateful to Jill and colleagues in terms of looking at how we can be part of the solution, but it is a complex solution because of the short-term funding, short-term contracts which exist within the community sector. But I agree in terms of Sarah, in terms of the timing is really important because we risk, if we don't invest in it, we're going to lose it. And then the burden comes through our front door and there's 800 plus people who are suddenly going to turn up and it's going to cost us £350,000.
Okay, your point is well made. Thank you, Ewan. There's a few comments here. Chantal, and then I'll come to Lee. And then I want to close the item with the Chief Exec.
Thank you, Chair. It's just to pick up on a point that Sarah made in the so what question, because when I was looking at the update, whilst I could see that there was a lot of work that was being undertaken, there's very little emphasis on the impact of the work that is being done. And I just wondered whether at future events that we could have a look at that impact to see in terms of how the progress and how we are aligning primary services with what we do as an organisation.
Yeah, I think I think that's a good question. I think it is about impact and it's about consequence of that. Ewan's just indicated the fact that there is something going on. Anyway, the question is, how do we connect into that kind of work? Lee.
Yeah, just briefly, I think obviously what we're describing is a very
Pull the
sorry, it's a very. Ooh, open the microphone. Is a large and complex system really. So, and I think so. In the midpoint review, this reference in the paper, I think a couple of considerations, reflections that Jill and I have had is that we have expected individuals within Jill's team and so on to try and progress this in addition to their core jobs. So I think there's a challenge there for us that we need to reflect on. And the second is there is clearly overlap between this work, the urgent care work, and the social model for health work. They're not exactly the same, but there's quite a lot of overlap between them. So I think there's a further reflection for us, which is how do we put the right support and resources in place to facilitate those three pieces moving in synchronization so that they are both happening at the same sort of timelines, Sarah, but also allow us to make the progress that we want to make. So I think just picking up on the kind of reflections now, I think we will take that away in relation to the midpoint review that we've just undertaken and consider what we should do to progress it from here.
Great, thank you. I'm going to close this item with a final comment from the Chief Exec.
Yeah, thanks very much. Look, and yeah, this is, as everyone said, complex, and it doesn't. We do need to see it as a primary care and community services strategy. We're trying to link it to sort of Karen's work and the social model work and the overall review of our strategy. I think the point that Jill and Ewan made, that whilst this work's been going on, we're also delivering change and transformation, and have been for a number of years. And that I know Jill mentioned the point about the work around our opticians and ophthalmology service. You know, the shift left there. That's an example. I mean, and Ewan's talked about the work with our third sector. There are a whole range of areas. I think we've made progress over the last 2 years. I suppose this paper wasn't designed to try to describe that progress that we've made. It was designed to try to work out, show the progress on developing the strategy. But I think in the end, the basic point that we would all be behind is that we would want some urgency in this work, and I think we would all agree with that. I do think we might need a bit of external support to get the kind of pace that we need on this, and we need to discuss that as an exec team. Just that I think to get sufficient engagement, the complexities that Jill and Yuan were describing there, sufficient engagement, so that we get to a conclusion where we've got sufficient sign up from all the relevant parties when we produce the strategy, I think will be really important. And to do that in the kind of timeline that I think we want as a board, we'll probably need a bit of help, given our experience over the last couple of years. So if you can allow us to just, Lee and I, Jill and others, just to work on that quite rapidly, we will obviously update you on the progress on that.
Okay, fine. So I think what we'll probably say in terms of the paper, we're happy to endorse the next steps. What we would want to see is that traction around what you're suggesting, Phil.
Yeah.
In terms of additional support and probably that midpoint review to be able to look at some of the things that have been achieved in the interim along this way, Lee. I think that would give people an assurance that things are not waiting on the strategy, things are being delivered anyway. And not to underestimate the fact that it is complex, and it's a good job, it's a great job that the team have been engaged in developing, and it is something else they're trying to do at the same time. Okay, thank you very much. Let's, I suggest we break for lunch, 30 minutes, and then we'll reconvene at 2 o'clock. Thank you. chap on and yet still dedicate sufficient time to feel that we've given them a good airing. Can I take us to our next item, which is creating a sustainable dentistry service with Jo?
Yes, thank you very much, Chair. And again, I think this is a really important item for the board. We're often aware politically of the interest that our public and the concerns that our public have around our dental services, not only here but across Wales, and certainly also from our profession as well. So what I've done just at the outset of the paper is really to set out the services that make up our dental services. Often we're talking about the general dental service that people know on the high street, but actually our service is comprised of a range of services. So our community dental service, which operates across the health board, our oral health promotion and education service with things like our Design to Smile programme, Gwen Beef, our care home programme, and the work that we also do with schools, and then our tiers 1 to 3 dental programmes, which we commission from external providers in the main, both through other dental practices with that specialist expertise, but also through Swansea Bay, and then our orthodontic service, which is commissioned across the health board. So a range of services that we know we have as part of that overall provision. Now, one of the things that I know we are concerned about is our access to NHS dental services. And in 2018-19, we were achieving 42% against the Welsh Government target, which was 55% at that time. Now, we know that that has declined, and we can see that in today's terms, if we were looking at that 42% target, that would have equated to about 236,000 episodes of treatment. But today we know that we're really only achieving about 120,000 episodes of treatment. So a significant reduction really in the capacity that we have available through our general dental practices. So that's a real concern for us. Contract reform may have had an impact on that, but I think it's really important to set out that the principles of contract reform are very, very sound, looking at trying to change the emphasis on the way in which we provide our dental services through our GDS contract to those with the greatest need. And that, of course, does mean that there's a reduction then in the more routine consultations. And people, I know over the years, have said, I'm not being seen by my dentist anymore. I used to get seen every 6 months. The usual recall period now is 2 years. And so it's actually about targeting the resources that we've got to those with the highest need. But we know that since contract reform has commenced, there have been complexities around the metrics between seeing new, historic and urgent patients, and that has resulted in the fact that we have seen some contracts terminated. And you can see that we've now reduced the practices that we have available providing NHS dental services from 47 to now 35 across our health boards. So our availability of NHS dental services on High Street is reducing. There are ongoing contract negotiations, however, so we don't know yet what that final position will be, but we want to make sure that we have the services available to our population. We've also got service challenges in terms of workforce recruitment and retention. We can see that we've got a shift from dental practices providing more private care, and we've got a reduction in the number of dental training practices as well. And again, that's fundamental to the delivery of our services going forward and having that career progression. And we know often is said that those who train locally stay locally, so we want to make sure that we have sufficient training capacity through our practices to fit within the rural model of dental care that we may have with Hywel Dda. So I think looking at our population then and saying, well, what impact has this had? Well, actually, positively, although it hasn't necessarily improved, we can see if we look at the oral health of 5-year-olds in 22-23 and compare that with 2015-16, you can see that the severity and number of dental caries actually hasn't changed. It's still not good enough, and we still need to make sure that we can do better. But it is slightly reassuring that despite the challenges we've talked about, or I've raised in the paper, that hasn't yet had an impact in terms of that. I think we're also seeing a real change in the way in which patients access our services, and we're seeing a significant number of individuals coming forward now with high dental need, and that may be due to the fact that that care is less routinely available to them. So 28% of patients coming forward are needing 4 or more treatments. And we also know over the last year or so that we're seeing a significant increase in the demand of people presenting with urgent need. And we do have an urgent access service, but that's at 16% of the total activity now, and that's double the level it was prior to pandemic 2020 in terms of the pandemic. The other thing that I think is really important to point out, however, is that despite a 50% reduction in the courses of treatment available, we're actually seeing an increase in the level of investment. So that has increased from about 14 to 15 million in terms of the investment that's going into our dental services. So again, it's really important that we recognise that fact. I think what we therefore need to do is to say, how do we fix this? What can we do as a health board to ensure that we do have a level of progress in terms of the services that we want to see available for the future, but how can we increase the capacity that we've got? And I have taken a paper through our executive team for consideration that would look at using some of that underspend that we are seeing through the handback of contracts. So it is really only spending our budget, but seeing an investment of 1.6 million in this financial year and taking that to 2.7 million in the next financial year. But it's really made up of a number of components, and I think it's important that the board sees the comprehensive or the roundedness of what we're really trying to build here. So the first would be about improving access and trying to create additional capacity with NHS dental services. And we know that the particular areas where we do have problems is in Pembrokeshire and Ceredigion. So what we would be wanting to do as part of this process is to commission an additional 2 dental contracts that, if we were successful, would provide a level of activity for 8,000 patients. Now, having said that, we know because of the challenges of contract reform that there could be a reluctance to commit to 2 new dental practices engaging in that level of contract with us. So what we're also suggesting in the short term that we use some of the procurement regulations that have changed very recently to allow us to use some of that resource to provide a number of short-term contracts for up to 8 months that would provide a level of activity for patients in the interim whilst we plan for that longer term. But we also want to supplement that with some of the an opportunity in North Ceredigion by innovatively using our CDS service, our Community Dental Service, to provide a model of a GDS service, which you can do under the regulations. And again, that would be innovative for us, but would enable us to provide a level of service for 4,000 patients in that area. Now, managing demand is going to be significant, and what has also been introduced in recent years, and it's a national requirement now, a national development that exists across the whole of Wales, is something called the Dental Access Portal. And if you're not currently affiliated to a dentist, and affiliation means that you need to have been seen by that dentist in the last 4-year period, you should be registering on the DAP. And either by doing that on the health board website, or actually calling our dental team to register a patient onto that dental access portal. And currently what happens when we have activity or when practices are able to take new patients, then we will allocate patients from the DAP to the practices where there is available capacity. And already we've seen an allocation of over 1,000 patients from the DAP into some of our practices. So we're asking for some support as well through our plan around building the capacity and the administrative capacity and support to enable us to streamline that process. And although it says here, I think that 11,000 patients are on the DAP, I think that's up to about 13,000 now. So that is the route that you need to go through. We also want to look at our workforce development, and the plan includes an opportunity to pilot a second year of the NHS Dental Postgraduate Training Programme, which we believe would enhance the skills of graduates who are already completing their training, but build in some additional skills around minor oral surgery, etc., through that dental foundation phase. And we do have, because of the commitment given on this, a trainer and 2 foundation dentists already in place to start delivering that programme from September 2025. And we believe, again, that this will enhance the capacity and the skills of dentists who want to remain in the area and provide some of those additional services. I also talked about the importance of prevention and oral health. We currently have a Design for Smile programme which goes into our schools. But what we would be wanting to provide again through the programme is to deliver an additional 2 fluoride varnish applications to individuals in year 6 so that we can improve the oral health of our children at that early age. And this will deliver an evidence-based intervention to an additional 1,500 pupils. In addition, we would want to make sure that if there were any individuals identified through that process where dental caries were identified, then we would provide a referral into a dental access for those individuals. So I think trying to make sure that we've got that rounded approach to our services is going to be important. And finally, what I'd want to look at is thinking about some of those areas where we've got gaps within our consultant provision, in some areas of quite high need actually in terms of paediatric dentistry and special care dentistry. And they're areas that currently our patients have to travel outside of Hywel Dda to receive services elsewhere in Wales, mostly in Swansea. But by actually building into that capacity and recruiting into those posts would mean that we would be able to bring those services back into Hywel Dda. And then finally, looking at urgent access and trying to streamline the process there would be about recruiting some additional dental nurses to make sure we've got appropriate triage so that patients were allocated into the right pathway. And I have mentioned then the importance of digital, and that's been a common theme today, and making sure that we maximise the opportunities that digital can give us, both from a clinical and administrative point. Now, this plan would take us up to 2027, but we would start to look in October 2026 about some of the areas that we may need to adjust and to build on the plan that we have are recommending to the board today would allow us to build some of that sustainable capacity. And I think just 2 final points that I think it's important to draw to the board's attention as well. With the reduction in individuals registered with NHS dentistry, it means that something called our patient charge revenue is reduced significantly. And that's a source of income that the health board would collect as part of the fees that NHS patients would need to provide. So that's decreasing. Now, we've covered that off within our financial forecast for this year, but in years going forward, unless there is any agreement around that, it will significantly reduce our ability to commission capacity for patients going forward. And that's something we're in discussion with Welsh Government about as part of this plan. And then the final bit, which some board members will recall if they were around probably in 2017, I think was the last time we discussed this. Our dental budget is a ring-fenced budget that's meant to be used solely for primary care dental services. But what we have historically done as a health board, and as other health boards do, is that we fund the range of other services that I set out at the beginning in terms of our community dental service, our tier 1 to 3 services, out of that ring-fenced budget rather than from a hospital and community health services budget. And that's to the tune of 2 million. So I think it's just something that we have to recognise. That's something that the board could revisit, but at this point in time, it's a position that has been accepted and approved by the board when we previously considered it, and it does mean that those other services are funded. And at the moment, we're in a position where we are underspending on our primary care ring-fenced dental budget, so that is a position that can be covered off. But we know it's something that Welsh Government are intending to raise with health boards going forward in terms of further opportunities that could come from that funding. So I hope that that sets out, Chair, for you just an overview of some of the challenges, but how we've tried to approach this through thinking in the round, really, around the aspects that we need to be able to provide that sustainable dental service going forward. Thank you.
Thank you very much, Jill. Very comprehensive. Colleagues, any thoughts? You.
Chair, I'm very conscious, thanks Jill, very conscious we had a conversation earlier around our financial position and our run rate being a key, I guess, measure of our financial success this year, and we've naturally got a proposal which increases our run rate here. I'm conscious that we've got that happening in two places, actually, in dental and in planned care, as we increase our activity. But I think this is something that I would support as a process regardless. I'm very conscious and always have been assured by the robust procurement processes which Jill and her team follow, and the robust contract management that Jill and her team followed. So I think we can take assurance from that as a board that when the activity is delivered, the activity will be delivered and will deliver value for us as an organisation. I think that's really important. Nonetheless, there is a net resource ask within the paper. I don't foresee it being as significant as you've outlined, Jill, not least because there may well be some other handbacks of contracts in the meantime. So I think we'll probably see a degree of this washing its face within the budget. It's difficult to put a number to that at this stage, but I think I would support this at this point in time, recognising we've got a piece of work which is broader, which is the Appendix 2 review, which would require a quality impact assessment around all of our spending decisions between now and the end of the year. But I wouldn't want to block this at this stage.
Great, okay. Anna.
Thanks, Sharon. Thanks, Jill. I think it's really helpful for the board to have a bit of a reminder about just the sheer complexity of this area of work that doesn't always get much of a profile. So it's really helpful to have the detail that we've got here. I wanted to ask specifically, Jill, about dental decay and any other outcome measures we have, particularly for children. Do we have any way of cutting the data that we've got by demographics to understand perhaps socio-economic disadvantage within that? And if we do we have a way of triangulating that with other data where children and young people are unable to access support? For example, are these the same kids who are on an ND waiting list? Are these the same kids who are not getting their vaccinations? Do we have a way of putting that picture together?
Yeah. I think we do. We get, I think, an annual report actually from our dental public health colleagues in terms of our children's dental service and demographics. So I think there's probably something that we can bring together that would look at the sorts of metrics that you've indicated. And we do know that actually individuals in our most deprived communities will often have a level of dental decay that is at its highest. And I think part of the programme around Design to Smile and going into schools does target individuals through that process to try to address or mitigate some of those issues, and to develop some of the habits of tooth cleaning and as well as the fluoride varnish at that very early age. So I think it's something that, again, we could look to bring back into either another committee or to a board seminar to bring some of that information together. Thank you.
Chair, if it's helpful, I'd be happy to take that back into QSEC as and when there's a data set to have a look at.
Very good. Okay, that would be very helpful. Michael.
Yeah, thanks, Jill. Thanks for the detailed report. My interest was pricked by the community interest companies point. So I know that's just a small part of the whole thing, but how viable might that be as something to explore, or are we exploring it? Where might that go? Because I think that's a very interesting kind of thinking, slightly, differently again. So where would that? Where are we with that, and is that something we could be looking at?
So when I mentioned the community interest companies, was that in the previous paper?
Oh yeah, as well as there's kind of two papers, aren't there? But
yes.
just sorry if I've
haven't-
asked at the wrong point, but it's just
particularly
something.
thought about community interest companies in terms of dental. However, you could be thinking about clusters commissioning as a community interest company, the way in which they might commission services. And we think as well in terms of whilst the initial stages around the model I talked about in the paper that is yet to come from Welsh Government is going to be particularly focused on general medical services, it will have an alternative provider of medical services looking at other contractors and independent sectors. So yes, I think if we're thinking about the provision of services for our community based on population need, then that's something that we could look at. But the community interest company model itself, I probably haven't thought about in terms of dental specifically.
Yeah, because I looked at it, they have got them in Suffolk.
Yeah.
It's like,
Yeah.
and they are a dental focus, yeah.
Within our clusters, we have dental collaboratives are expected to be a key part of that. It's not something that's progressing as far as we would like in terms of Wales, but there's an opportunity for thinking about how we work with our dental contractors around different models, and this has to be part of that future discussion.
I mean, it does feel to me that, what we have in front of us is a heroic effort to address an enormous challenge. And to do that in a feasible and realistic way. And I think that comes very much across in the paper. I do wonder whether, as part of taking this forward, we remain open to radical propositions that could follow other models. The Scottish model in terms of the child smile model, working at a much earlier age for children in school, or looking at paid individuals working within primary care in a different kind of model. I think we should. So my view is this is a really good step for us forward, and it'll get us to 2027 and deliver a very good impact. What we have to do is continue to think beyond that in a sustainable way for the wider population, because this still won't tackle everybody.
No. And the other thing I should have said, sorry, Chair, was that Welsh Government have just undertaken a public consultation on dental services. So again, we will understand the impact of that and the outcomes going forward. But that may again encourage us to think differently around the models of delivery.
Great. Okay. In the interest of time, I'm going to move us forward. So, can I assume that we note the content of the paper, the work that's been undertaken in this area, and the 2-year investment plan, notwithstanding Hugh's concern about how we ensure that we fund it sustainably, and that we take assurance from the steps being taken to improve sustainability of NHS services across Hywel Dda University Health Board.
Thank you.
Great. Okay.
Thank you.
Thank you. Okay, can I move us then to the Fragile Services Framework Update Report? Sharon? Mandy? You don't look like Sharon at all. But, thank you, Mandy.
So the report that the board has received provides an update on the development of the process for us to identify across the health board services that are at risk of becoming fragile, but also provides a methodology for assessing those services and then responding to support those services. So the framework has been 18 months in development, and the methodology has been developed to ensure that we've got clear articulation of the risk that services are experiencing using the traditional risk management matrix and the risk register. But we've added in addition, we've also got additional fragility criteria now, which is aimed to try and identify what the fragility of the service is and then score it, which can then be added to the risk score. And we've also incorporated then, so moving on from that, once the service is identified as fragile, we then move on to for teams to work through opportunities where they could maybe manage some of the risk associated, and maybe particularly around leadership using the IHI framework. We've also, escalation thresholds have also been agreed, which and also associated governance arrangements, including a centralised register, so that provides the visibility for the board. So the escalation thresholds are intended to ensure that low fragility services that score low on the fragility scores remain within the oversight of the clinical care group, and those with higher scores are escalated appropriately and where appropriate to board. And this is in line with the requirements of the Fragile Services Domain for NHS Wales Oversight and Escalation Framework. So I think, as advised in previous papers, so the Chief Exec's report and the Chair's paper, the framework has been presented at a recent board seminar and discussed in detail, and you've got the slides that were presented there, and also considered at Quality and Safety Committee and has been approved, and the escalation framework has been approved by the executive team. So happy to take
Thank you,
your
Mandy. I'm going to use Chairman's prerogative. I had a question which is really about the criteria. I wondered where culture and engagement play out in defining a fragile service, because it does feel to me it could be an opportunity for us to reconcile our engagement data, you know, with what we might think is a fragile service. It needn't just be about locums and workforce numbers. It can be about how engaged and you know, how engaged and consequently how productive or motivated individuals are inside that space.
Yeah, I definitely would think. I think some of that is covered in the IHI framework, but it wouldn't specifically measure it as part of the fragility score.
It feels to me it would be useful for us to think about how that plays out in the measurement of fragility. Colleagues, are there questions or thoughts? Anna?
Just briefly, and to follow up on your point, Chair, I would say, Mandy, that actually the key difference between this latest iteration and previous is that it incorporates exactly what you're describing. Now, there are going to be ways that we could get that more and more finessed over time and include more and more workforce metrics that would, you know, fine-tune and make richer that understanding. But I think if I've understood this correctly, Mandy, what we're trying to guard against here is that we end up in some sort of reconfiguration situation when actually what we needed was some work to help the team work better together, or to strengthen the leadership, or to do something around what would be called the softer aspects of service delivery. So whereas before it was very much about sort of the configuration side of things, now it adds in that component around sort of leadership and culture, and should enable us to find the right, you know, the right solution for the problem that's actually the problem, not the problem that we perhaps misdiagnosed, as it were.
Yeah, absolutely. Absolutely. It feels to me it's quite pragmatic in that regard, which is very helpful. Okay, I'm not going to dawdle you if people are comfortable with that. Can I just then accept the fact that we support the work that's progressed to date in relation to being able to evaluate our fragile services and recognise the potential presented by the framework to influence organisational culture and learning systems and improve risk mitigation. Great, okay. Can I then move us on to Prince Philip and the minor injuries unit update? Please, Mark.
Diolch, Cadeirydd. So following a board decision in September 2024, the minor injuries unit at Prince Philip Hospital enacted a temporary overnight closure. This was in response to serious clinical safety issues and an inability to staff the unit medically overnight. It was agreed to develop and appraise options for the unit for a long-term model if we could not return to the previous one. This, unfortunately, has not been possible because we have not been able to recruit sufficient doctors. Board thus approved a 12-week consultation, which has just completed on the 22nd of July. The board has also approved to extend the temporary closure until we have been able to implement a long-term option. You will recall that we've consulted on 4 options. 1, a 12-hour doctor-led unit. 2, a 14-hour doctor-led unit. 3, a phased return from a 12 to a 24-hour doctor-led unit. And fourthly, a 14-hour urgent care centre. It's important that we reassure everybody that we have no preferred option, and we will consider any new options that are in scope during and following the process of conscientious consideration. We have developed a very comprehensive and flexible consultation process, and Alwena will now take us through this and also talk us through the midpoint review.
Diolch yn fawr iawn, Mark. Thank you. I won't go through the paper in detail line by line, but I just wanted to take the opportunity to provide some assurance that we have followed a comprehensive process for our consultation. You'll see that we've held a number of events and provided an opportunity for people to engage with us and share their views. These have included both conversations with our staff, but also our broader community. We've also held them online and in person. I appreciate that the paper was presented at a point where we were just after our midpoint review, and therefore is not the final data that we've had at the close. So close, as Mark mentioned, was last Tuesday, so the 22nd of July. At that point, we'd received just over 730 completed questionnaires, which is a significant improvement on where we were in the early weeks, I was pleased to say. And I think that is largely due to a concerted effort on a number of bases, including members of SOSPAN and Llais, who have been side by side with us. Also recognising the role of various community groups that we've engaged with, and the efforts of our colleagues in going to sit in the minor injury unit to seek the views of people actually using the service. We're now in the process of analysing the feedback and obviously understanding what we're hearing before we go into the process of conscientious consideration. So I won't go into the detail of exactly what we've heard because we are in that data analysis piece. But I would like to just share that Hywel Dda Company, who has been providing assurance for us, at the point of the paper being presented, they provided assurance for us on the midpoint review, and just yesterday they provided assurance to us on the process that we've taken up to the closing date, appreciating that this is a process and so far they are assured by the steps that we've taken that we are listening to our community, that we've provided enough opportunity for people to be part of the process and informed of the process. With that, I would like to hand back to Mark for the next steps, but just like to thank our partners and members of the team who have really gone out and gone above and beyond, if you like, considering that we've got the clinical services plan and the minor injury unit consultations running at the same time. So it's a big ask of our community and our staff to be doing both. So thank you.
Great. Thank you, Arwana.
Thank you very much, Arwana. So yeah, what are the next steps? So we now are entering a period of conscientious consideration. This will include the 4 options and any other additional options that meet the scope, the hurdle criteria and the evaluation scoring. But I think what's important to remember at this point also is what is not in scope. So changes to the acute medical assessment unit, re-establishment of an A&E in Prince Philip. I think we very much recognise that is something that we have talked a lot about during the process and had a lot of good conversations about why that is not in scope. But we very much respect the opinions of individuals who wish to get that across to us. Changes to the GP out-of-hours service is not in scope, and also closure of the minor injuries unit, or indeed even moving the minor injuries unit to another site. So the analysis and development of a final report will be overseen by the steering group and the project group, and we still plan to report this to board in September. How we will do this is described in Annex 3 of the papers. Much like Arwana, I'd really like to thank our staff who've worked incredibly hard, the staff who've engaged with us, and our other stakeholders, the patients and public, and also SOSPAN and Llais and our elected representatives who've really engaged with us, have given us good challenge, and as a result we've had good conversations. So thank you to all of them very much.
Very good, thank you. Just in terms of, so you mentioned that we had a spate of last minute kind of responses, which is great news. Do we still think the September timescale is realistic in terms of the analysis of that data?
Shall I come in on that one?
We could both.
I think, to be completely honest, there is concern within the team in terms of the analysis of the information. We have had a number of alternate options being presented as part of that, and we need to give them due consideration. So to go through the process of do they meet a hurdle criteria? Can they be looked at by the group that looked at the options development process? We do have a number of meetings in place during August where we will go back and conscientiously consider what we've heard with our staff, with the group that supported us in the option development process, with our steering group, the project group, and with board seminar later in August as well. It is very, very tight, I'd say, and it largely depends on what we hear as part of that process. So it's a little bit early to call it this second, but we are a little bit concerned that it is very tight in that analysis.
Okay, so my sense is we should take assurance from the process to date. It feels very comprehensive, and I think we've got to a good place in terms of giving people confidence that it's not a decision that's been decided. And I think you're right, Alwena. I think what we should do is if we get some viable, interesting alternatives, we have a duty to explore those as part of finding a solution in Prince Philip Hospital. So, and we can't sacrifice those for the timescale. So if it means we have to rethink our timescale, then we will do that. We will do that. If, of course, if those are not there and we can manage it by the end of September, that would be great too. Michael.
Thank you, Chair. I'll echo what you say, and as someone who's been involved in this kind of thing 10 years ago, very pleased the mention of Sospan and Llais being very much at the centre of all this. I think take a lot of assurance from that and from the process. I would also, just as what you're just saying now, if the feedback is about alternative models, that will take a bit of thought. So I can see where you're coming from, Alwena, on that. Okay, yeah. So supportive on that. One point I want is something I keep banging on about is the issue of transport, because I bet you, if I'm a betting man, if I was a betting man, I'd bet that was one of the main themes going out in all this. And so, how much have we been able to engage with and find out the situation of things like local bus companies and the like? Because I think that is going to be important thread in this process. So have we kind of dealt with them? I'll ask them about, or had any kind of interaction with them as to how all that fits in.
I think part of so thank you. We have looked at an element of the transport analysis, and to be fair, this is a theme that we're hearing through all our consultations and conversations with the community. It is that how do we access, and particularly at a point of need, because you're not necessarily going to have a bus at 2 o'clock in the morning. Not that the MIU necessarily would be open at that kind of time of day, but it's an issue for our geography. The team have been looking at the transport analysis to look at the impact of any option when it comes into that. If your question is specifically around have we engaged with bus companies specifically, or anybody beyond WAST, so WAST have been at the table with us and round as part of the steering group and the project group, and they've actually attended public consultation events with us as well, and we're really grateful to them for their input. So they've been able to guide us in that sense, but beyond that, when it comes to community transport and the like, I think it's a case of, depending on what option we develop, how do we then look at mitigating some of that impact? But I couldn't give you an exact answer as to have we had a specific response from a particular group, because we're in that data analysis point at the moment.
Michael, let's wait to see what comes through, because I think you're right. I'd probably support your proposition as well. I think transport will be a big issue, but let's see what comes through finally. I mean, one of our overriding features, not just in relation to this, but also into the clinical service plan, is not to create an additional level of disadvantage by the kind of clinical decisions we want to make inside this space. We have to make some tough decisions, but what we don't want is for patients, especially those who are most vulnerable, to be more disadvantaged by the consequence of our decision making. And if we think that's the case, we have to find ways to mitigate those circumstances. Great. Okay. In the interest of time, I'm going to move us on. So thank you very much for the paper, and we take assurance from the process to date, and we look forward to the next stage being completed. Can we move then to National Outpatients Assessment In-Source Project? Andrew.
Yes, thank you, Chair. So I think I won't go through the paper because I know colleagues will have read that, but just a couple of comments of introduction, I guess, context. This stems from the Cabinet Secretary's mandate and desire at the start of the year to see the total volume of outpatient waiting list across Wales reduced by 200,000 patients by providing additional capacity in which to see patients, and the support of that being that it will help shorten overall waiting times later on in the pathway as well by reducing the number waiting at that first stage. To support that, Welsh Government undertook a national procurement process to identify capacity for 200,000 patients to be seen across Wales, and that's been split into two parts. The first part was around the finding in-sourcing providers to deliver 164,000 patients, capacity of 164,000 patients over the course of this year. And the second part was around health boards delivering a local additional capacity requirement of 50,000 outpatient appointments. Our share of that is a total of just over 16,000 appointments, 2,600 of those through our own local arrangements, and the balance being provided through an in-source provider. We have obviously been engaged in those conversations nationally through the procurement process and to get to this point. The paper sets out that one of the omissions in the national tender process was that it didn't necessarily cater for, at that point, all of the potential in-year revenue costs that health boards might face from delivering this level of activity, even with the in-sourcing element. We've subsequently, as the paper identifies, received confirmation from Welsh Government that they will fund a proportion of that, but it does leave us with a potential financial risk this year to deliver the full amount of activity in the way that we were originally intending to, which was a multi-site delivery model across Hywel Dda of just over £100,000. We believe we can mitigate that through the year, and there are various options for us to do that. And it does seem like, from our perspective, to be able to see 16,000 patients that are currently waiting for an outpatient appointment seems like a fantastic opportunity for us to not want to progress with, but recognise that in the context of some of the conversations we've had today and some of the conversations we'll be having in the coming weeks, there is a potential risk there that we will need to manage. As I say, my team are fairly confident we can manage that, but I just need to flag that.
Thank you, Andrew. Colleagues, questions? Or Maynard and then Anne.
Thanks, Andrew. Quite clear paper. My concern is not so much around the funding, but a lot of the background work on this in terms of retrieving red recs, getting data back into our systems, etc., is inevitably going to fall to our existing staff. And that's how they're going to increase.
Maynard, pull the microphone towards you.
Yeah, it's okay. Whether there is an appetite amongst the staff for the amount of overtime and extra work that will create, or whether we're going to struggle to deliver the extra appointments, not because of funding, but because our staff are worn out.
Yeah, no, I think that's something we're actively working through. Some of the resource that we identified that had been missing from the original national tender process was around the capacity to provide some of that administrative support. So the additional funding that Welsh Government have put forward is aimed to help support that. There was an element that within the contract around, I want to say £200,000 that they had already awarded that was to help coordination and manage some of the process that you're describing. So there is I guess within that there is a challenge then in terms of us being able to identify the staff that would want to come in and join us on a fixed term basis to do that at this point to the end of the year. So that's something we'll have to watch closely and monitor and manage for the reasons you've described.
Thank you. Mine's very much similar to Maynard's. The elements I'm getting back is, will we be able to staff it because it's going to be weekends, sometimes in the evening? Are you going to get paid overtime? And it says to be induction staff costs for training and etc. Additional potential year costs to be counted. It's not actually in the figures. You've got portering in there and cleaning, but we haven't got the records staff. So it doesn't seem to be well looked out around what we're going to need from our side to put this into place.
So the additional work that we undertook to identify that gap identified that, and that's in part what the additional funding that Welsh Government have provided us is aimed to cover. The issue around induction of staff, so just the staffing question, it's important to recognise that the vast majority of this work is based on the premise that this is an in-source provider coming in to do this activity, and one of the criteria those providers had to confirm nationally as part of the process was that they were able to fully provide for the level of activity with staff from outside of Wales, not just rely on staff within Wales to deliver that. So that's an assurance they've given as a provider for that element of the contract. The challenge, one of the issues we're working through locally within the local element, which is the 2,500 appointments, is that we're not sure whether we will get the take up from our staff to want to do that additional work. We know we've got the clinic space to do it still, but we don't know whether our staff will want to do that. So we are working through at the moment the option of a further insourcing contract to bridge that gap so that we can provide that capacity. The induction of all those staff will follow the same process as we follow for our agency staff, so there will be a programme of induction for staff coming into the organisation as well. We've got a meeting with the provider on Monday where we're just looking to finalise that.
Thank you for that. I think the concern was having somebody who knows the site on when the staff come in, whether there's extra healthcare, extra support with the consultants and rooms and allocation, and where is this, where's that? And they were like, well, are we being paid for this? That's the question I'm getting at the moment. And you've just said that you're looking at...
Yeah, and I would imagine anybody that is working overtime on the weekend still out of hours to cover these clinics will obviously be reimbursed appropriately for doing that.
Thank you.
Great. Anna.
Yeah, thanks, Chair. My question is about the capacity modelling logic here. So this is about increasing capacity for first outpatient appointments. No. Andrew, I'm not necessarily expecting you to know this off the top of your head, but do we know what percentage of our outpatients are seen and discharged in a single appointment?
Yeah, so we assume in all of our capacity modelling there's around a conversion rate of about 30% from outpatients to then going on to require some further kind of diagnostic and treatment.
Sorry, because I think this is a really important question, the data analytics. Of that 30%, would we predictably understand across each of the specialties what that percentage is?
Yeah, we would have an understanding by specialty based on past experience and past activity what we would expect it to be. The average is about 30%. One of the issues that we have raised with as part of this process nationally, and I know there are further phases of this recovery plan that Welsh Government are still considering, is the event of, so for those 30% that come on, they're obviously going to come through the process much quicker. So we're creating a wave of demand then for stage 2, which would be diagnostics. And we're not sure, we flagged at the moment, we wouldn't have the capacity to deal with that as quickly as we would want to be able to deal with it or how we would normally deal with it. And that's a conversation that's live at the moment with Welsh Government around once they start to see from the first month or two's activity what the pattern is, how they then support further capacity to deal with some of that wave, either in diagnostics or with therapies input or other kind of aspects of that, because we are also conscious that it brings forward a group of patients for treatment, although it should mean that the 104 weeks becomes far easier to deliver at the moment, which is the sort of target. Hope that helps.
If I could just briefly come back in, I mean, I think that is a really important thing for us to understand in making this commitment to move ahead with this decision, because in effect what we're doing is shifting a bottleneck into a different place. Now, that's with a smaller cohort of patients, But we know we already have bottlenecks around diagnostics, so which will only be made worse by this for some people. So I suppose it's just important that in making one metric look much better, as we'd expect this to, i.e. your access into your first outpatient appointment, we still need to be very scrutinous in terms of, well, what is that doing for the next stage and the next stage, because those hidden weights are not doing anything to improve clinical outcomes for those individuals. They're only hastening them towards the next bottleneck. Yeah. So I think there's some sort of tempering around the excitement on this, isn't there, that is important and that we need to track in the outcome metrics that we have, or the performance metrics we have in other places of the pathway.
Okay, you needn't come back on that. Well, that's fine. Hugh, and then finally we're going to come to Phil.
Yeah, Chair, supportive of the processes being followed. I just want to highlight a risk to the board that we will pick up in discussion with ops colleagues and procurement colleagues around the tax treatment of in-sourcing arrangements. There's a distinction whether it is a provision of healthcare services, which is VAT exempt, and the VAT burden falls on the supplier, or a provision of staff for which VAT would then apply and the burden would fall on us. There's an added challenge that HMRC would then potentially require us to almost treat this as an agency, and we would then need to undertake checks on employment compliance of the staff members involved. I say that just because it's an active risk that we're managing. This is a national procurement exercise, but of course, we are a sovereign body and need to be satisfied ourselves in terms of that position. Team will work with Ops and Procurement to work through that, and we'll work through the Audit Committee on any implications that may arise.
Thank you for that reassurance.
And I guess just to add that, and just to try and help with assurance, this is also a provider that we've worked with before on an insourcing basis over the course of the last 12 months. So one of the benefits to us is we know them and we know how it's worked previously, so that should help us keep a very close eye on that and monitor and make sure that doesn't become a real risk, as Hugh's identified, because it is one that we're conscious of and have flagged in the national conversations as well.
Great, thank you.
I think part of the issue is HMRC somewhat changing their view on it as well, so we just need to keep live to that ongoing discussion as insourcing becomes increasingly used across the NHS, across the UK. Clearly the risk profile also increases.
Yeah. Very helpful. Okay. Sure.
Yeah, thanks. So I think Anna's raised the question that I was going to ask Andrew to reflect on. I suppose not everybody would progress to the next stage. So there's a large percentage of people who will be seen, get advice, and be able to continue with their lives then, who wouldn't have been able to if we weren't going through this process. So I think this is, from that sense, that's really good news. In my conversations with government, same as Andrew, that the support that we've had for our 8-week diagnostic target does not include the additional diagnostics that will come out of this work. And they recognise that, we recognise that. They've done a significant amount of work looking specialty by specialty on historic information to work out what percentage roughly of each specialty would need diagnostics going, because it does vary from specialty to specialty. So we have gone back to them with our data on that, and they're working through that, and they recognise that challenge. And it does at least get us to that point then where we have another question, which is, well, how do we manage that extra diagnostic need? And we're looking to work with Welsh Government to see how we resolve that. So in a way, I see that. I think we need to be, as a board, cognizant of that, and the public too. But I do see this as a real positive. I think we are, just to flag two other things, we are responsible for the clinical governance of this activity whilst it is undertaken on our sites. So there are implications around that for the kind of scrutiny that we will need to apply, and I'm sure Quality Safety Committee will want to apply that scrutiny for assurance. The other thing just to flag is, of course, with patients coming back who've been seen by by an in-source provider, there will be some patients, additional load, who come back for follow-up that our teams wouldn't have had as a follow-up yet. So there's not just an impact on diagnostics, there's also an impact on follow-up. And across our clinicians, there will be, I'm sure, a variety of views on how that works. I'm sure, though, that in the end, this will be overall a positive thing, and I hope we can support it.
Something Phil's just said then about responsibilities. Just thinking there's also an information governance responsibility and a Caldecott responsibility that probably needs to be considered by IGESI.
Yep. Okay, so let's note the progress that's been made around this. And like you, Phil, I think it's a positive idea, if not least for 70% of those people who will feel they can get on with their lives. Approve the award of the contract to Healthcare Business Solutions UK, and also note the actions, as I think Hugh has outlined, in terms of mitigating additional cost pressures which might fall out of this for us as a board to have to respond, and to defer that to the executive team to manage going forward. Great, okay.
And consider the HMRC issue.
Well, I would say that's in the cost pressure space as well. Yeah, definitely. Okay, fine. I think that takes us to the end of our items, and we're moving into maintaining good governance. We want to work through our committee papers. I'm just going to give people a 2-minute refreshment break to get your head out of all those papers we've been talking about and just re-energise for the next, the final section of the meeting.
No, I'm not.
Consider that not invitation then.
You'll be in hospital, sweetie.
Oh, yeah.
How long are you in for?
Okay, thank you folks for coming back from that very quick, re-energised session. Can I just then move us straight away into report of the Audit and Risk Assurance Committee? Rodri.
Okay, thank you, Chair. Well, from the 24th of June, you can see I take the report as read. There's a couple of things I just want to raise. So we had the Audit Wales Review of Urgent and Emergency Care, AEC report, and the associated management response was received with all recommendations accepted by the Health Board. You can see from there the need for better access to GP records for STEC and improved staff engagement was highlighted, while GP out-of-hours services already have access. System integration across healthcare remains a challenge, requiring a unified approach. The report highlighted issues and concerns around staff engagement and a blame culture, which should be addressed through the new operational structure, which aligns community and acute services together under one leadership team and will be a clinically led approach. Then the Audit Wales Planned Care Review report. 6 recommendations were made. Concerns were also raised regarding inconsistent clinical prioritisation of urgent cases and the need for better risk stratification. Additionally, it was noted that support services like radiology and pathology are often overlooked in funding applications aimed at reducing waiting lists despite their vital role. Standards of cleanliness, internal audit report, you can see from that, recognise that some progress had been made since 23-24. Several of the actions remained ongoing with the associated risks not fully addressed. This was disappointing, very disappointing, and in response, a smart management response is being developed, supported by a task and finish group working alongside nurses, colleagues. Therefore, if we go on to the Assure, we can see the Health Board's escalation status now includes a specific requirement to respond to Healthcare Inspectorate Wales, HIW, and also HEIW. HIW also had some concerns regarding whistleblowing, potentially linked to recent organisational changes such as the OCP and Clinical Services Plan. If we move forward, you'll see there's a revised ARAC terms of reference that needs to be approved, and also SFIs. And I will kind of take the rest of it as read. I've picked up the most important parts, therefore, I don't know if you want to go to recommendations, Chair.
Great, okay, thank you, Rodri. If there are no questions or comments, can we...
Just on the blame culture point, because it doesn't... Just on the blame culture point, because it doesn't give the sort of context, unless I've missed it. My understanding, the context of that was that it was what was heard was that the acute was blaming community, and the community was blaming acute for issues of not progressing urgent and emergency care progress, and of course that's something very much that is a key part of our urgent emergency care programme that we're working together, and the operational structure that we've set out actually puts people overall responsibility for both, actually, to help solve that. I'm just checking, I'm saying that out loud because it doesn't give the context in the paper.
Okay.
Yeah, it was more the acute blaming the community rather than the other way around, but the details in the paper which we can share with members as well.
Okay, thank you for that clarification. Can I then agree that as a board we approve the changes to the terms of reference?
The changes are marked in red, so it's quite easy to see.
Yeah. And also that we approve the standing financial instructions changes? Yep. Great, okay. Let's consider those agreed. Thank you, Rodri. Diolch. Can I move to the report of the Quality, Safety and Experience Committee?
Thank you, Chair. Yes, the report stands. I will just briefly mention the 2 alert items. The first regarding a patient's story that we listened to around our emergency pathway. Obviously, we have had a lot of discussion about that in board today at a system-wide level, so that is clearly in train and very much on the board's radar. The second issue relates to issues around the quality of our estate and to what extent we are really sort of tuned into the details around where we've got deficits in our estate, which may be driving some of our infection prevention and control issues. And this arose out of a walkabout on a ward in Glangwili that for 3 years, with a whole series of walkabouts, has been raising issues over its bathrooms. That specific issue led to a wider question about how our walkabout intel feeds into conversations around prioritising what we know is a capital allocation which is grossly inadequate for what we need. So that issue is being looked at currently to ensure that we do have a good join up between what we're seeing on walkabouts and then what gets discussed through the proper process of resource prioritisation for capital improvements. James, I think, did you mention earlier on that you were going to comment from an IPC point of view or a state?
Thank you, Anna. I certainly did. So I think just to address the point, so the Quality Safety Experience Committee and Audit Committee have both requested updates on the internal audit and cleaning standards, which they'll receive in the August committees, which is on track. What I also should add is myself and the Sharon as Director of Nursing, Quality and Patient Experience are reviewing some of the processes which are in place at the moment to ensure that we do have the sufficient oversight with the interdependencies between infection prevention control standards and the standards of cleanliness, which we know we currently have concerns about across the organisation. And we'll be able to give a more comprehensive update during the next committee structure round. Thank you.
Thanks, James. And just one more thing, Chair, that is to approve our terms of reference as well, please.
Yeah, great. Okay, thank you. Any comments or reflections? Okay, thank you for drawing to our attention the patient story, because I think you're right. I think it amplifies everything that we've been talking about today and is a reason why we need to address it at a systemic and local level. Thank you, Anna. Are we happy to, are we content to support the changes to the terms of reference? Yep. Great, okay. Thank you, Anna. Can I move us to our next report of the Finance and Performance Committee?
Yeah,
Michael.
Thank you, Chair. Actually, you'll see a lot of the alerts and advise are really what we've talked about in the board today, which I think that's how it should be in a way. So that's good. So I'm not going to go through that. What I just wanted to say, I want to assure the board that we are working actually hard to try and streamline the committee papers, because there's a lot of times where information is repeated, and also to, in terms of performance, to focus on some key issues and to understand within those issues, again, these are the matters which we've talked about today, to understand within those actions taken, to track those actions and track their effectiveness. That's something we really are working on. That's a work in progress on the committee at the moment. But apart from that, I ask you to take the report as read. We're asked to approve about non-prepared and prepared fruit. So it says, refers to a bird. I'm not sure we've got a name of...
I can pick that
up. Yeah,
can
you pick our fruit for us? And then, and so there's been some amendments to the terms of reference. Asked to ratify that, and as I take the rest of it as read, Chair.
Okay, thank you very much, Michael. So, colleagues, are we content to, having been alerted to these issues, are we content to accept them? Yes, that's our next item, though, isn't it? So we'll pick that up as the next item. We'll pick up the fresh fruit and details at the next item. What we do need to do is to ratify and agree the revised terms of reference. Great, okay, fine. Thank you, Michael. Hugh, let's turn to you and the procurement report.
Chair, yes, I will ask you to approve the fresh, non-prepared, unprepared fruit, which seems to cover all fruit in those categories, but for some reason we call it non-prepared and prepared. So if I could ask for approval to for that item, that is an All Wales procurement item, and the second one is the All Wales continence product, which is being supplied to Ontex, and then the third item then is the principal contractor for construction of the fire improvement work in Withybush. Chair, those are the three items that are over £1 million that require board approval.
Thank you, Hugh. Are members content to approve those procurements? Right, okay, thank you. Agreed. Can I move us to our next item, report of the Strategy and Planning Committee? Maynard.
Thank you, Chair. Last meeting was on the 1st of July. The committee had no items on which it wishes to alert the board to, but we'll bring out one of the one item to advise, which was that we felt quite strongly that the annual plan needs to be more considered in the context of a 3-year plan, and that one without the other doesn't really make sense. So we want to report on that at the next meeting. On all the other items, the committee was assured. There are a couple of papers following, which with your permission I'll hand over to Lee.
Great, thank you. Lee.
Thanks, yes. So just I'll pick up the paper on the maturity matrix. This is the third year that we've undertaken. Third year that we've undertaken an assessment of our planning maturity, and we discussed the outcome of that in some detail in the Strategy and Planning Committee. I won't go through it in detail. Obviously, if people have questions, I'm happy to receive them. But we're seeking board approval of the scoring that we ended up with at the end of that process. So happy to take any questions, Chair.
I have a question. I note that we've declined in terms of our strategic, the first measure on the maturity matrix. As I read it, I had a sense that was a little harsh as a self-assessment, because we do have strategy in place. You know, we're largely revising that and refreshing and renewing that. And I know I talk about a strategic vacuum, but largely we are working to a strategic framework in terms of what we're trying to deliver. That was just my view.
Yeah, so just on that, you've hit upon, I guess, the one that probably provoked most debate. Certainly, I'd say my personal view on that was, as you say, which is we haven't lost our strategy. What we've done is add to it through the clinical services plan and the strategic refresh. I think we probably were erring on the side of probably being more self-critical than anything. But that said, it does remain the case that there's a lack of clarity about some key questions relating to the strategic direction of services in West Wales, and obviously we've had some of that discussion today in terms of estate, infrastructure and so on. So I think there'll be multiple views, and we had a range of views within that, and this reflects the average of those views essentially.
Great, okay. And I am conscious in some of our consultations, some of the views back, and certainly from some of our local authority members is, where are you going? What are you doing? You know, wanting some of that clarity around our direction of travel, and we might have that or be in the process of allowing that to form, but we really need to share that with our wider partners as well. So fine, okay, just my thoughts.
We're in the process of a strategic refresh as well.
Yeah.
Great, okay. So if people are comfortable with that, can we approve application of the seal for all schemes listed in Annex 1? Approve the scoring of the maturity matrix as we've just discussed for 2-year review prior to the submission to Welsh Government. Approve the submission of the business justification case to Welsh Government seeking approval to progress with the Withybush General Hospital Phase 2. note the items the committee is advising on, and take assurance from the items that the committee is providing assurance on. Great. Okay, thank you very much. Let's move to, well, I'm presuming we'll have covered off the planning maturity matrix update.
Yeah,
as part of that. We're okay, Joe, to consider that the same?
Yeah.
Great, okay. Can we move to business justification case, Withybush Hospital, to support phase 2 of fire enforcement? Notices, James.
Thank you, Chair. So, if I take the paper as read, so the report sets out the next stage and the final stage, delivering the strategic capital investment necessary for the fire enforcement notices in place at Withybush General Hospital site. The Strategy and Planning Committee received the report and have approved onwards ratification to the board, and I'm asking the board for support for submission of the business justification case to Welsh Government. Happy to take questions.
Thank you. Colleagues, is everybody comfortable with this? It's a meticulous, fairly detailed piece of work that is premised on phase 1, completion of phase 1. So in that sense, there's a compelling argument behind it. Great. Okay. Yes, we are supportive of that, James.
Brilliant. Yeah.
Can I take us to report of the People, Organisational Development and Culture Committee? Eleanor.
Thank you. We last met on the 27th of May. I will take the paper as read by everybody. There are only a couple of things I'd like to draw your attention to. One, in the advise, there's an issue around culture, which I've discussed with the chair of the Quality Committee as well, and with HR. We are expecting the paper to come back next time for us to consider, and it links some of the items we've already spoken about, which is what is the culture that's coming up in the engagement report, the links across to fragile services, the behaviours of people, and actually the leadership and the challenges in there for the culture of our organisation. So it underpins some of the things we've talked about today, and equally Anna and I reverse roles as chair and vice chair for people and then quality. So it is well linked in that space. So we would also like approval of the new terms of reference, please. And I'd just like to thank Michael for taking on the role of champion for the armed forces after Delyth Rainsford left the board. Appreciated. And that's it. Thank you.
Great. Okay. Can I just?
Of course you may.
I think we've in the details of the paper we've referred to the Equality, Diversion and Inclusion Task Force. I don't think we're diverting anybody.
No.
So
that tactic clearly failed. Yes.
So perhaps we
Thank
could
you,
just,
Chair. Apologies, Chair.
That would be helpful. Any other comments or questions? And are we happy to approve the terms of reference? Yep. Note the items the committee is advising on and take assurance from the items the committee is providing assurance on. Right. Okay. Can I take us to item 24, report to the Health and Safety Committee? Anne.
Thank you very much. We met on the 3rd of July. We didn't have any alerts, but we had a couple of advice, and that's mainly around the Health and Safety Subcommittee update report with our compliance with health and safety, fire and security training. There was identified concerns around the compliance of level 2 fire training. An extraordinary meeting had been conducted and action plans developed to address this. The other concern we had was the underreporting of RIDDOR, which is the Injuries, Diseases and Dangerous Occurrence Regulations. So this was a submission across the organisation, and we asked the Health and Safety Subcommittee to update on our current position. While the internal audit update report and associated action report demonstrated progress towards meeting the requirements of the Health and Safety Committee, the final internal audit report, the committee was only able to take limited assurance due to the number of outstanding actions, and an update was requested for the next meeting. The rest we were assured about. We accepted the subcommittee's terms and reference, and the board is asked to approve the major incident plan note the items the committee is advising them of, and take assurance that the items of the committee is providing assurance on. I thought this would link in really well with the major incident plan, but they're not here.
No, they were going to join us online, but I'm of the view, because it's already been approved at committee. Thanks to Sam, who was prepared to join us on the call. Because we're short of time, we won't cover that offhand.
That's fine. Yeah, we were happy to approve it.
Great. Okay, that was the important step for us, I think, as a board. Okay, so can we, on that basis, approve the major incident plan, note the items of the committee we're being advised of, and take assurance on the items that the committee's assuring us on? Great. Okay. Fine. Can we move on to item 25, report of the Charitable Funds Committee? Ewan.
Yep, thank you, Chair. Again, take it as read in terms of with colleagues, but the committee met 17th of June. One alert for colleagues, which is in regarding to the ongoing development of the therapeutic gardens at Prince Philip Hospital. Costs have become significantly higher than we first were advised of and envisaged, but we're working with colleagues in terms of looking now at receiving revised costs, which will be brought to our September meeting. But we're currently looking at an increase of, we currently foresee about £106,000, but that will be confirmed at the September meeting. But we wanted to alert colleagues in terms of the increasing cost that we've seen at the therapeutic gardens development. But again, we're grateful to colleagues who are working with us in terms of giving us the correct and necessary information for the committee to then make an informed decision from that point. In terms of advise, there is nothing listed on the paper, but I want to correct that, as noted by our Vice Chair, Sarah, who kindly kind of pointed out that there was one advice which we wanted to bring to the attention of the board, and apologies that it wasn't included within the report, which was just to kind of note in terms of advising to colleagues in terms of the reserves which currently sit within charitable funds. There's 10.7 million as of the 31st of March 2025, which is a drop on the previous year of 12 million. And there was a debate at the committee in terms of should we be sitting on such a large reserve? Could this be spent elsewhere? But it is something which we are going to kind of revisit, I think, at the next meeting in September in more detail. But we wanted to advise, thanks to Sarah, in terms of the board and bringing that to your attention today. In terms of assurance, you will see the items there. Nothing that should jump out. So we're asking in terms of, as with similar kind of committees, the approval of the terms of reference, 3 changes, 2.1 regarding the word charity rather than health board, 3.3 in terms of strategic development, and 4.4 in terms of updates to the risk register. And you will then just in terms of response to the item that we're alerting to, and obviously take assurance from the items that the committee is providing assurance on. I just would like to thank all colleagues across the Health Board who engage with the Charitable Funds Committee and spend a lot of time putting the bids and applications in to work with the team. Happy to take questions.
Diolch, Ewan. Fine. Colleagues, questions or? No? Okay. We will wait with bated breath the outcome of your conversation about how do we spend £10.2 million, because in fairness, if I was giving money to the charity, I would want it spent rather than accumulated in a bank account. So there's something about, you know, although I appreciate it's difficult for the committee as well. Thank you, Ewan. Are we happy to approve the changes to the terms of reference? Yep. Fine. Okay. Report of the Digital Data and Innovation Committee.
It's going to be a verbal report, Chair, because it was only last week we met.
Yeah.
There's one item to alert the board to, which is the LIMS 2.0 project, as the implementation pathway of that has now been revised. Instead of doing it on a health board by health board basis, is going to be implemented on a specialty by specialty basis across Wales. This unfortunately results in an additional cost of £176,000. An approach is being made to the Welsh Government for the additional funding across Wales to be met from any slippage in the 25-26 Digital Priorities Investment Fund. So the board is asked to, one, approve the revised implementation approach. We honestly don't think we've got any option in that because it's being agreed at an all-Wales level.
Yeah.
But note that if the funding is not available from Welsh Government, the Health Board will need to find an additional 176,000. We're not sure of the timing of it, how much of it will be this year or next year. We had no items we wish to advise on. On Assure, in innovation, we received the implementation plans for the Research and Development Strategic Plan, and we received an update on the progress of the Tritech peer review and confirmed the governance of that for its future business plans. In digital, we picked up the planning objective report, the digital operational plan, the digital strategic update report, strategic partner update report, digital inclusion report, but there was some concern expressed in that, not enough to advise, but it's just a very small team doing an awful lot of work. We received an update on the progress of the patient flow in the OB system and the radiology informatics system programme, and the progress on the exploration of potential application of ambient AI and the ongoing pilot studies across Wales in the use of AI scribes. Finally, we received a GSC update and approved the mobile working policy and a report on data quality. We reviewed 2 risks, which were risk 2079, loss of pathology services due to delays in the implementation of LIMS 2, and risk 1352, possible of business disruption due to a cyber attack.
Thank you. Thank you, Maynard. Hugh.
Chair, thanks, Maynard. I think they're very clearly articulated. LIMS naturally is a national programme, and the additional cost we've included in our thinking about next year's plan. I anticipate it being a cost that falls next year, but if it does impact this year, I'll make sure that's articulated in the finance report. We don't have much choice in this. We're going to have to follow through with the All Wales approach.
Great. Okay. Thank you for the clarification.
I was just thinking of the importance of this subcommittee, and on one side, it trying to keep us safe and making sure our programmes of work have the right governance and progressing well. But then on the other side of it, making sure that we're keeping pace with all the change and we're harnessing all the opportunities as well. I was just checking, is that is built into the remit of the committee?
Yes,
it's both.
Yes.
Yeah.
Yes.
Very much so.
There's an internal
and if it
contradiction.
wasn't, you wouldn't let me forget.
No.
Yeah, that's why I'm just checking.
There's a tension. There's a tension inside the committee, which is hopefully a creative one.
Yeah, good.
Yeah, great. Okay. Thank you both, and thank you, Maynard, for the update. Can I move us on to committee update reports, Jo?
Yeah, thank you, Chair. So the final report covers the other remaining committees or groups that report into board. So it covers the Ethics Panel, the Mental Health Legislation Assurance Committee, Remuneration in Terms of Service Committee, Health Professionals Forum, and the Partnership Forum. From all of those groups or committees, there are no matters to raise to the board. However, as you'll see in the paper, there are 3 advised matters. One from the in-committee board, which was on urgent emergency care, which we've covered today, Chair. And then there's a matter from the Health Professionals Forum and also from the Ethics Panel, which will be discussed at a future board seminar. The board are asked to approve the Mental Health Legislation Assurance Committee terms of reference, but also, Chair, just to flag a governance point, because unfortunately we didn't follow due governance in the last MLAC committee, and there was an approval item within the report to increase funding in relation to Section 12 doctors, which is outside the remit of the committee, because, as we're aware, committees don't have any authority to commit expenditure. So we flagged that to the board, and that's being discussed outside of that forum, Chair. But I thought in terms of governance, I just needed to be open and transparent about that, Chair.
Okay, thank you. Thank you for that. Colleagues, any points you want to raise? Or shall we just run through? So we need to approve MHLC terms of reference. Is everybody comfortable to do that? Great, okay. And then obviously to acknowledge we've received an update reports in respect to work undertaken on behalf of the board. Note the items that are being advised of, take assurance. Everybody supportive of that? Great, okay.
Chair, sorry, it was remiss of me to say Dr John Arthur is here today in his first role as the chair of the Health Professionals Forum and will obviously be becoming an associate member of the board. So I should have said that when introducing the item as well, Chair. We're just preparing the letters to go to the Cabinet Secretary now.
Thank you. You're very welcome, John.
Thank you.
Let's move to item 28, joint committees and collaboratives.
Yep. So this item gives an update on 3 joint committee arrangements. The papers are all there. We haven't got a Mid Wales update because of timings, and there will be an update for the board in November. Just say that I've taken on the Chief Exec lead for the Mid Wales arrangement. So the other point I was going to make is our regional joint committee, our next regional joint committee of Swansea Bay is taking place on the 18th of August.
Great, okay. Duly noted and received. Okay, can I move us to statutory partnerships update? Jill?
Yes, thank you, Chair. I just want to note really the work that's going on, first of all, in the PSBs. We often talk and make reference to the wellbeing plans, but it does give a flavour of the local level of discussions that are taking place that are linked to the population needs within each area. The bit that I just wanted to highlight in terms of the RPB, however, was that the Part 9 regulations, statutory regulations, have changed. They were amended in January and published in April, and that provides us with an opportunity to review the membership. So I provided the membership documents to the Director of Corporate Governance, and I think we're going to have a conversation through, first of all, our executive team, and then probably bring something back to board around whether or not it's the opportunity now to revise our role in the Regional Partnership Board and potentially IAG as well. So we'll look forward to that discussion at a later time. Thank you.
Thank you very much. Bethan, I'm just wondering if you wanted to add anything on Fiona's behalf.
Only to note really the conversations have commenced with the 3 PSBs around joint working, and they're now working to develop an options paper.
Very good. Okay. Yes.
And just on the Pembrokeshire PSB, the new chair has been elected, and it's Mark Tierney, which is excellent. I've also stepped down as vice chair, and the new vice chair is Jess Bickerton. So I think that'll be excellent going forwards for that PSB.
Very good. Let's note on the minutes, Claire, our congratulations to both of them. Very good. Okay. That takes us to any other business? No other business. We've obviously got the board annual work plan for information, and date and time of the next meeting will be 9:30 Thursday the 25th of September. Thank you very much.